motor speech treatment. As the topic goes, neurobiology of change, mechanisms and mode of action in motor speech treatment. This topic explores how brain mechanisms, neural plasticity and evidence-based intervention approaches contribute to improvement in motor speech disorders, helping clinicians design effective and targeted therapeutic strategies. To moderate this keynote session, we are privileged to have Dr. Suman Kumar, Director of Ali Yavar Jung National Institute of Speech and Hearing Disability. Sir, may I request you to kindly join us on the moderator's seat. Thank you, sir. Our keynote speaker for this session is Dr. Arvind Namasivaya, Adjunct Professor at University of Toronto and Director of Speech Research Centre Incorporated, Canada. Ladies and gentlemen, the speaker will be addressing us online. We warmly welcome Dr. Arvind to this virtual platform. I now request the moderator to kindly take over the session.
Good morning and good evening to the keynote speaker, Dr. Arvind Namasivaya. And we are privileged to have him for this international conference. He was supposed to come physically, but due to time constraint, he could not make it. So we are glad to have you, sir, and I think now the floor is yours. You may proceed, please.
Okay, are we ready to go?
Yeah, please.
All right, thank you. Once again, unfortunately, I couldn't make it. I'm teaching this term in Canada, and I can only do this online, so please bear with me because this is going to be an online session. I'm going to share my screen. I'm not a big on Google Meets, but let me see if I can share my window, maybe. Okay. Can you see my screen?
Yes, we can see.
I am just going to make this.
It's fine.
It looks good on your end, right?
Yeah.
Okay, perfect. Okay, so thank you again, Suman. That was a nice introduction, and once again, my name is Arvind Namasivaya, and I'm from the University of Toronto. We're going to talk about a super interesting topic today. We all have done speech therapy at some point in life, and the question is, why does it work? Is it a placebo effect? Is it something to do with psychology? Is it something to do with behavior change? Or are these effects measurable in the physical sense? So that is the big question, because in speech pathology, we have kind of neglected this question. We have data in dysphagia, for example, like you have we do video fluoroscopy and we can see if there's aspiration or not. We do hearing aid testing and we can see when you put aided hearing aid, the hearing threshold is different. But for some reason, nobody really went into, when you do speech therapy, when you teach the kids how to speak, is it just placebo, or is there something more to it? Are we really changing something in the child? And how do they learn to speak? So that's the big question. So we're going to specifically talk about this little square box which says motor speech disorders. I circled two other things on top. I'm just going to walk you through that. On the top it says distal causes and etiological processes. Distal meaning it could be environmental or genetic broadly. Those can result in what is called as proximal causes. Proximal meaning it is close to the symptomatology that you see in the clinic. For example, Apraxia is a disorder that is supposed to be arising from speech motor planning and programming. And you have dysarthria that is arising from execution. So the symptomatology that we see in our clinics goes back to what the proximal causes are. You could have speech delay from genetic otitis media or psychosocial issues. So each of these disorders have a specific cause from where we are actually looking at. Now we just focus on something called a speech motor delay, dysarthria, apraxia, and apraxia plus dysarthria. So those are the categories that we're looking at. Why are we focusing all our time on motor speech disorders? Apraxia, dysarthria, motor speech delay, apraxia plus dysarthria, and so on. Why is this population so important? This population, if you've ever done speech therapy and kids are not changing, you'll probably come across this population because they are very resistant to traditional therapy, whether you do articulation therapy, phonological therapy like minimal pairs or any of those phonological interventions. They are at the greatest risk for long-term speech problems, meaning by 13, 14 years of age, by 16 years of age, they still have some speech problems going on. So motor speech disorders are resistant to regular intervention and they have the long-term outcomes are not that good. So I think this is a population that deserves some more attention. But part of the problem has been we do all of these interventions, but we have never really asked, are they effective? Why are they effective? So the key is to identify why they are effective, figure out early diagnosis, and do the right intervention for the right population so that we can produce the right changes in the client. So I think that is where we are kind of falling behind in motor speech disorders. Now, the National Institute for Health and Care Research said if you did research, you should measure efficacy and mechanism of evaluation. So what is mechanism of evaluation? I'll come to that in a second. Efficacy we all understand. Efficacy basically means, is the therapy efficacious? Meaning, does it work? If you do this therapy, do you see a change? Then the question is magnitude of treatment. If you do this therapy, how much change can we see? Are we seeing 1 standard deviation? Are we seeing 2 standard deviations? In terms of effect sizes, is it effect size of 1? Is it greater than 1? And so on. How much therapy gives the best result? Once a week? Should we be doing twice a week? Should therapy be done 3 times a week? So those are all dosage questions. For example, if you take Advil for fever or paracetamol for fever, you know that you take 1 tablet every few hours. How much therapy for children with different disorders should we be giving? So those are the questions that are related to dose. Then the question is, what predicts positive outcomes? What should you be changing to get the best positive outcomes? So we've had some answers for this. There's tremendous amount of work done in this field. And this is, I think, in the last 10, 15 years, has kind of, I would say, ballooned out of proportion. There's like probably hundreds of papers right there in this side of the talk. Unfortunately, on the other side, which is the basic science, what are the mechanisms of action? How and why does treatment work? That is what has been neglected. If you ask this question, for example, we recently had this COVID, right? And going on Zoom or Google Chat actually reminds me of back in the day when everything was shut down and we were doing the Zoom calls. So when they came up with this vaccine, they actually tested it on 44,000 participants, the mRNA vaccine, for example, right? And they did a randomized trial to figure out how effective it is. But they couldn't have done it if they did not do the basic science, which is find how the COVID virus looks like, figure out that it uses something called as a spike protein, and then build antibodies that attach themselves to the spike protein. So that is what we refer to as mechanism of action. You need to figure out why something happens so that you can produce the right treatment. At present, we are figuring out treatment by trial and error. It's not engineered treatments. So we are moving towards engineered treatments. Here are the three big motor speech disorders that we just saw in the first slide. You have dysarthria, CAS stands for child apraxia of speech, and speech motor delay is SMD for short. Dysarthria therapy is basically you do system by system. We are looking at respiration, phonation, articulation, resonance, you're building strength, you're inhibiting reflexes, you're giving biofeedback, you can use alternative augmentative communication devices, AAC, or there's another treatment called as prompt, which we will look at it in a second. Apraxia has its own set of interventions. You have what is called as dynamic temporal tactile cueing, biofeedback with ultrasound, a therapy called as rapid syllable transition, which works with nonsense syllables. Once again, we have prompt, we have Neufeld dyspraxia program from the United Kingdom, and the Kaufman speech to language protocol from the United States. So there is several interventions for these types of disorders. I'm not going to get into the details of it because today is not about what therapy is, today is why therapy works. Okay? What we're going to focus now is this intervention and this intervention. Prompt stands for prompts for restructuring oromuscular phonetic targets, uses motor speech development, figures how the jaw develops, the lip develops, the tongue control develops, and then uses targets based on that hierarchical development, and it targets social, emotional, cognitive, linguistic, and the sensory motor domains. The motor speech treatment protocol uses targets again from a developmental perspective, but also uses syllable structure, like consonant, vowel, consonant, how syllables are formed. And then it has a very strong home training component. So the motor speech treatment protocol was developed in Canada, in the province where I live, and it is very popular in all preschool government setups here. So we're going to focus data from these two. Let's focus the neurophysiological mechanisms. I have broken down this based on data that we have collected from the lab, primarily from our lab, in the last about 10-15 years. Some of this data is related to kinematics, or how movement changes underlying motor speech intervention. Coordination, does motor speech intervention improve respiration, phonation, articulation, and resonance? Does it improve the coordination? What is the magic sauce or secret sauce or the magic ingredient, which technical term for that is active ingredient, in motor speech intervention? And we kind of know that it is the tactile or somatosensory input. And what is the mode of action at a neural brain level that corresponds to these changes? So, in 2013 and 2014, some of our colleagues actually ran a study, and with markers on the face, as you can see here, what they found is if you track the face during motor speech treatment, the changes in these markers in the jaw and lip and face system is associated with improved speech intelligibility. So we know that what we are doing in motor speech intervention is actually changing how we move our lips and jaw, and that is reflected in improvements in speech intelligibility. But the question is, how is speech intelligibility related to motor control or movement? So we ran another study for this. What is the relationship between motor control and speech intelligibility? If you're a parent sitting here or if you're a speech pathologist, we know that the families come to us, our parents come to us, my child is not intelligible. They are not understood by, their relatives, the school system is not understanding, the child's friends are not understanding, the relatives, uncles and aunts, when they come over, they do not understand the child. So that is one of the biggest problems when you have motor speech issues. Speech intelligibility is affected. Here's some of the data. This amazing data set that we did in 2013, Goldman-Fristow test of articulation, that is GFTA2. So on the horizontal axis, you have Goldman-Fristow 2, which is an articulation test. WINPAC is verbal motor production assessment. FOC stands for focal oral motor control. And again, WINPAC is a motor test, and SEQ stands for sequencing. CSIM stands for Children's Speech Intelligibility Measure, that's in green. And BIT is Beginner's Intelligibility Test, and that's in purple. And that's a sentence level test. So the green and purple are word level and sentence level assessments. So if you look at this graph, the y-axis, the vertical axis is correlation, Pearson correlation. What this tells you is 40 to 50% of intelligibility comes from WINPAC focal oral motor control, which is just how you move your lips. Can you open your mouth? Can you round your lips? Can you retract your lips? And beginner's intelligibility test, sentence level test, CSIM, the word level test, they both are highly correlated to motor control. Same thing with sequencing. It is correlated with word and sentence level intelligibility. The Goldman-Fristow, which is a test of articulation, how many sounds the child is able to produce, do they produce it in initial, medial, final position? A simple articulation test is not correlated to speech intelligibility. We found this in 2013. I'm writing a paper right now as we speak, and we looked at this in a completely different population. 15 years later, 16 years later, we have exactly the same outcomes from a very different population. So we know that motor control dictates speech intelligibility. So if there's anything that you're going to be working on, you should be targeting the motor system. In fact, 70% of the variance in intelligibility comes from oral motor control and your ability to sequence. So a lot of this data comes from prompt, and I think it kind of tells you that if you target the motor system, you can produce good results. Next, I want to shift to what is called as subsystem coordination. Subsystem meaning voice onset and lip movements. In this case, for example, I want everybody to just try and say pa for a second. Go on, try it. Just say pa. So when you say pa, the time from your lip to your voicing, the ah, is about 40 milliseconds. No matter what you do, if you said pa, that's how long it is. If you said ba, with the ba, like that, it is less than 20 or 30 milliseconds. So speech is coordinated in milliseconds. Under 30, you hear a ba. More than 30 or 40, you hear a pa. Now that is the foundation. Now, I want you to walk you through the data here. On the top, it says control group. So the control group is saying pa, pa, pa. And you can see the distribution of voice onset. It is all from 40 milliseconds, 50 milliseconds and up. In the middle panel, you can see children with speech motor disorders. And what you can see is their voice contrast is all over the place. So the middle panel has data. So they're actually saying pa, but it sounds like ba sometimes and sounds like pa sometimes. So there is data below 50 milliseconds, which causes the confusion, so they don't have sufficient voicing control. Now, after therapy is the bottom panel. So what happens after therapy is it goes back to looking like the control group. So if you put it in statistical terms, there is a statistically significant difference between pre-treatment, which is MSD pre, and the control group, but there is no statistical difference between post-treatment and the control group. You can see that the post-treatment distribution looks identical. There is no child making errors less than 50 milliseconds here. This again tells you, if you did motor speech intervention, you have adjusted timing so precisely in terms less than 20 or 30 millisecond difference over a span of 8 to 10 weeks of therapy. So this is significant, and I think this is one of the strongest data that says these are actually physical differences that you can produce with intervention. The question is, why are children with motor speech issues actually able to stabilize? So the theory is, again, we did a few studies back in 2013, 2014. The theory is you have voice onset problems because your jaw is not stable. So you might ask, oh, Arvind, what's the big deal with jaw not being stable and your voice onset not being accurate? What we found is if you vibrate the masseter muscle, like with a finger or like a tendon vibrator, so if you vibrate the masseter, which is a jaw closing muscle, it actually makes your voice onset time more variable. It increases your jitter and shimmer, which is basically your cycle to cycle vocal fold timing. And what we found is if you stabilize the jaw, voice onset also stabilizes. Now, from neurophysiology, we know that the masseter muscle is the only muscle that has spindles in the orofacial structures. Lips don't have spindles. There's orbicularis oris doesn't have spindles. There is no other muscle that has spindles. Spindles tell the system how much something has moved. So muscle spindle information probably is used to stabilize voicing onset because the jaw is getting stabilized. So there is a connection between jaw stabilization and voice onset stabilization. So this again we published in 2013. This is very unique because this is what we call as inter or subsystem coordination, or coordination between two systems with physiological data. Now, the big question, what is the secret sauce? Is there a magic sauce in motor speech intervention? In other words, if you add a painkiller, for example, Advil or paracetamol or something, what is the key ingredient that makes your fever go away, that makes your headache go away? Is it ibuprofen? Is it paracetamol? Is it acetaminophen? What is that ingredient that actually produces this result? So this study was done in 2013 in children with apraxia. And what they did is, it's an alternating design, meaning part of a therapy is given for some children, and afterwards the groups are switched so that they get full treatment. So what did they take away? They took away touching the face and giving the clues on the child's face, like, oh, round your lips like this, retract your lips like that. So all the cues on the face were removed for some of the children, and all the cues on the face were given to some of the children. So what did we find is, you can see that there's a baseline. Labiofacial is the lip and face, lingual is the tongue control, and sequencing is saying sounds like ah, oo, ka, ta, ka. How's the sequencing ability? The next panel is no TPK. TPK stands for tactile, kinesthetic, and proprioceptive, meaning all the touch cues that you're given. So if you didn't give any touch cues, what do we see? We actually don't see much of a change from baseline. It kind of looks like the baseline. Like it says therapy 1, TX1 and TX2 are similar to base 1, base 2, and base 3. With tactile, kinesthetic, proprioceptive input is the next panel, which is the third panel, where it says TX3 and TX4. The orange symbol is actually 2 standard deviations above baseline. So now you can see, if you touch the face and give the tactile cues, you actually see a 2 standard deviation change from baseline. And once again, that is maintained in the final session and also at follow-up. So this tells us that tactile, kinesthetic, proprioceptive, together we call it somatosensory. Somatosensory input is essential for the system to reintegrate itself or reintegrate other subsystems together. So that is one of the active ingredients. Now you might be wondering, where is this tactile input going? Like for example, if you just put your hand on your face, it gives you tactile awareness. You can feel the hand, you can feel it touching on your jaw, you can feel it on your lip. Is it simply awareness, or is that touch actually being processed for speech? So that is a key question here. So it is not an active ingredient if it's a placebo effect. Is this effect actually neural? Is it actually going up to the brain? To answer that, we said, let's do another study. So in 2022, we carried out another study where we said, let's do somatosensory input and see if it's just awareness, or is this information processed by higher level cognitive linguistic system. The question we proposed with the design is touching the face going to help in phoneme perception? Meaning, if I mix phonemes and noise, that makes phonemes difficult to hear, touching the face, does it help retrieval of those phonemes? And am I able to retrieve the words correctly? And what is my reaction time when I'm doing it? So that is how we set the study up. We have 2 conditions here. One is we had a congruent condition and we had an incongruent condition. And what that simply means is, when I'm hearing a word like, let's say, Baba or Papa or Mama, it is all lip sounds. When I'm hearing a lip sound, if I touch the lip, am I hearing the lip sounds better? Versus, you can see the other picture where I'm putting the hand under the chin. I'm trying to push the tongue up. So, if I do the lingual or the tongue cue, if I'm pushing the tongue up, that is an incongruent clue when I'm listening to bilabial sounds or lip sounds. So when I'm hearing mama and I'm pushing your tongue up, that is incongruent. So what you are hearing is opposite to what my hand is doing in the face. So we try to mix this up and say sometimes that what you're doing on the face will match what you're going to hear. Sometimes it will not match. Now, We also had high frequency and low frequency words. Why did we take high and low frequency words? Is because the main reason is the high frequency words are, the word frequency between the high and low frequency is called a lexical effect. Means the lexical processing, the word processing, is supposed to be at a higher cognitive linguistic level than just orofacial awareness. So if we find the frequency effect when you're touching the face, differentially between high and low frequency words, we know for sure that touching the face is accessed by the lexical system. Lexical system is where you process the meaning of words. So that is our hypothesis. Now, one thing we need to remember is when we play these audio files, here is an example for one trial. It says get ready, and then it says give the tactile kinesthetic input as instruction 2. Now they might be doing touching the lip for wa, which is like water, and they are supposed to take the hand away. So they do wa, wa, wa 3 times, and they take the hand away, and the person who is touching their face does not know what word is going to come next. So there is a slight delay, which is a randomized delay, and then the word comes mixed in noise. So the auditory target comes, in this case it is dance. So if I primed the lip, but the word is dance, it should not be helping that word, because I primed the wrong thing. It is an incongruent stimuli. So I'm touching the lip when I should be touching the tongue in this case. Dance is a tongue sound. What we found is, when you have incongruent input, meaning touching the face versus what you hear is completely different, it actually makes it harder for you to retrieve the target, and it also increases the latency in which you do it. And this effect is only for low frequency. High frequency words, meaning words that are very frequent in daily use, are not affected by this. Once again, these are healthy adults that we are doing it. And that incongruent touch on the face costs you 5% of intelligibility and about 100 milliseconds in latency increase. That is a pretty significant thing for an adult who has a very intact system. This study tells us that touch cues are processed by the cognitive linguistic system and is used part of lexical processing. So it does go up all the way, and it is not simply increasing in awareness of the person. Now, we are getting into what is mode of action. Mode of action is defined as what causes structural changes in the brain. What causes neuronal firing patterns to change in the brain. So this is where the money is. If we can show speech therapy actually changes the brain in even 10 weeks of therapy, that is amazing. It's just going to blow everybody's mind that even 6 to 10 weeks of therapy, you can see massive amounts of brain changes. Let's see what they are. So the first thing is, there are 3 things that we have found. First is the brain structure itself changes. Second is neuronal connectivity from the brain to the mouth also changes. The third is how the neurons fire in the speech motor and associated areas also changes in the same time period. So therapy actually changes. Let's look at each of these. So the first one is a cortical change in children receiving motor speech treatment. This we published in 2014 on children with apraxia. What we found is, if they received 10 weeks of therapy, the Wernicke's area, which is what we used to think as a comprehension area actually becomes thinner. So the left posterior superior temporal gyrus, which is Wernicke's area, becomes thin after what is called as prompt intervention in 10 weeks time. Now that is a significant thinning. We call this neuronal pruning. In development, you have excess neurons when we start, and with experience, we prune the neurons or take away the neurons that we are not using and keep the ones that we want. So that is pruning, and what we find is the Wernicke's area is actually pruned after motor speech treatment. Now, you're probably thinking, okay, in all my school, we have learned that Wernicke's is comprehension and Broca's is production. Why are we seeing Wernicke's area change when you're doing motor speech intervention? That's an important question, and the answer is the recent studies on Wernicke's area actually shows that it includes the representation of speech sounds. So it connects the speech sounds to the motor movements. So it's not just perception, but it maps onto the movements. So it is almost like the motor to auditory system mapping gets fine-tuned. So it facilitates more accurate representation of the speech sounds is what is happening once we do motor speech treatment, and we believe that this creates very stable motor programs that can be retried and sequenced correctly and produced efficiently. The next one is the mode of action, where we find the connectivity is actually changing. So this is a study from some of our colleagues, Fury et al. In 2021 and published again in another paper in 2022. Again, these are all very, very recent papers. Just in the last 10 years, we actually know this data. This is a super cool data. The figure that you're seeing on your left side with the brain is actually one of the participants' data. And what we find is, with 30 sessions of therapy twice a week, again, these are children receiving motor speech intervention, and these are children with apraxia. And what we found is, when you compare motor speech intervention to language intervention or non-speech intervention, so the L and OM treated in green that you see in the results versus prompt treated is a motor speech intervention. What you find is the dorsal corticobulbar tract, which is in that little red arrow, that is the connection that comes from the cortex, specifically the precentral gyrus and the frontal lobe, down to the facial and laryngeal system. What we find is in children treated with motor speech intervention, the dorsal corticobulbar tract that connects face, head and neck actually increases in thickness. So that purple line that you see on the first picture is the actual data from one of the kids, and that purple tract is the dorsal tract coming from the cortex to the facial muscles. And the children who received language intervention did not find this tract thickening happening. What is the big deal with the tract thickening? It probably helps in improved firing, helps in improved coordination, and likely facilitates subsystem integration, because now you have stronger connections coming down from the brain to your muscles. So the first thing is Wernicke's area becomes thinner, or neuronal pruning happens. Second thing is the descending pathways from the brain to the mouth and larynx get stronger. Third is the neuronal firing itself. Again, this is another study where they did magnetoencephalography, MEG. This we did in 2018. And what we found is children with speech sound disorders, once again, twice a week, just 8 weeks of therapy, And what we found is we have firing pattern changes in the regions that control oral motor control and speech production. Specifically, the inferior frontal gyrus, province area 44 and 45, the motor cortex, precentral gyrus, and insula. So anything that controls planning and actual movement and production, the firing patterns actually improve and synchronize with twice a week, 8 weeks of therapy. Now, once we go past all of this, let's just summarize the big picture. What did we see? Is speech therapy, specifically motor speech therapy, is that a placebo, or do we have concrete evidence that we have gone beyond just behavioral outcomes? We know that there are movement changes, which is kinematic changes, because we track the face with markers, and those markers improve, and that is corresponding to improvements in speech intelligibility. So therapy changes movement, and that improves intelligibility. We have established that. Therapy also changes coordination, and we know that speech motor intervention makes the proprioceptive or somatosensory information more reliable, and it allows subsystem coordination, meaning it allows the coordination of larynx and articulatory subsystems. And the secret sauce, what is the active ingredient? We know that the somatosensory input touching the face is the active ingredient, because if you don't do that, therapy outcomes are not good. Second, we know that that information is actually used for language and lexical processing. And that is, again, super interesting. And the third thing is, we know that if you do the tactile intervention or somatosensory input, we actually can find neuronal changes, such as structural changes in the neuronal pruning of the Wernicke's area. Second, we can also find changes in the dorsal corticobulbar tract, which connects the cortex to the face and larynx, and also the firing patterns in the motor cortex related to speech. So all of this together is the how and why motor speech intervention works. So this is the neurobiology, or so far this is what we have found, which I've summarized with. It's about 15, 20 years of research I've just summarized in 45 minutes so far. So, take home is, we know therapy works, we know how much outcomes we can expect, but we have also concretely established that we're not in the space of psychology, we're actually in the space of neurophysiology and neurobiology, because we are changing the brain, which is experience-dependent neuroplasticity, in a matter of 8 to 10 weeks of therapy that we do. So we can all rest assured go back to our clinics, and if anybody has any doubt, you could tell them, hey, there is actual data that the brain changes if you come to therapy, and that's why children get better. So, with that, we can conclude saying we should include efficacy and mechanism of evaluation. We must integrate these findings into our clinical practice, specifically use it to validate what we do, advocate for speech therapy, early identification and speech therapy, because it is effective, it is efficacious, and it does produce neuroplastic changes, specifically experience-dependent neuroplastic changes in the brain in a very short interval of time. A specific thank you to families who participated, over 40 plus research assistants in our lab, independent contractors, and the University of Toronto, and collaborators from around the world. My lab is run by Dr. Pascal Van der Schot, where I work at, and part of it is the University of Toronto, and thank you to the Ministry of Children, Community and Social Services that has funded a lot of this research. and apraxia kids, which is formerly known as Kasana. With that, I would like to conclude and open the floor for any questions. I'll just go back to my first slide.
We will now have a two-question interaction with the speaker. I request audience to keep it brief and relevant.
Hello, my name is Olaf Camargo. I work down the road from you in Hamilton, Ontario. And congratulations to this brilliant presentation. It was amazing to follow it, and so clear and so didactic. Very, very good stuff. I actually have two questions, or a comment and a question. I think if I understood correctly, and I'm a developmental pediatrician, and I really struggle in finding services for kids with apraxia of speech. It's terrible, even in Ontario, probably know, to get the right amount and the right therapy for these kids. When you describe the tactile interventions, I assume that these need to be very well timed with the production of speech. It's not a passive manipulation of this face, and I think just to confirm that. Good. The other question I have is, from what you learned with children with apraxia of speech, that is developmental apraxia of speech, we also see a lot of dysarthria in children with cerebral palsy. And can we apply any of these learnings maybe for this population, and should there be, for example, an early intervention for speech that we think about the motor skills and walking and all these things, maybe we should think early about speech and intervene earlier? I would appreciate your thoughts on that. Thank you very much.
Absolutely, thank you so much. And I'm super happy that somebody from Hamilton is right there. I would have been sitting next to you, but couldn't make it there. But good question. Very important point, that because if you're touching the wrong place on the face, we just showed that it can give you very different results even in adults, which means in a developing system pediatric population, if you're doing the wrong cues, you're actually going to confuse the brain more than facilitate it. But the other thing is, what actually happens is, if you have, I'm not sure if you're familiar with the PASS program, the paired associative stimuli in transcranial magnetic stimulation, where the stimulus from the brain, when it comes down, should be paired with the ascending afferent information. And when you pair them together is when your synapses form and your pattern, your motor programs and motor plans form. So the timing of when you're touching the face should be synchronized with the attempt the child is trying to do. You're right on it. We have amazing data on that from lip control literature and speech control literature with magnetic brain stimulation that has shown that the timing is critical. So that again reinforces you have to be highly experienced and practiced when you're doing these interventions. And there's special training, there's months-long training that we have to attend and get specialized. The other question is it beneficial for dysarthria and apraxia combinations? And most likely, it is very rare that you're going to see just childhood apraxia alone. It always comes with maybe language issues, dyslexia, maybe it comes with literacy issues, reading, writing issues, and dysarthria. The apraxia plus dysarthria category was only recognized in 2019 as a separate entity, as a comorbid condition that could occur together. And any of these motor speech disorders can benefit from prompt DTTC or Kaufman or any of those interventions. And there's lots of efficacious studies that show that this is really good to do. And I think it's definitely worth trying. There is no randomized controlled trials for the mixed populations, but there are randomized controlled trials for each of the interventions independently. But we don't have randomized superiority trials that says one therapy is better than another therapy. So I think that's where the data is. Hopefully one day somebody will do that. So I hope that kind of gives you a broad status of where things are at.
Good morning, I'm Sunanda, developmental pediatrician. I just wanted to know your experience of working with deaf-blind children with this. Have you had, deaf-blind children with apraxia?
Yeah, that is a very, very good question. I used to be an audiologist in my past life, and I gave up audiology, and now I'm a speech language pathologist. I haven't done any work on blind and deaf together as comorbid conditions. But what we know is with hearing impairment, the tactile input is actually very facilitative. Because if you have hearing issues, the somatosensory input is actually occupying a larger area of your auditory cortex. It's kind of expanded into, so is your visual input as well. So visual and tactile input will be more beneficial for children with, deaf and blind population. Interesting point, never actually been studied. Hopefully, someday we'll do more research on that. Again, this whole field is barely 15 years old in terms of collecting neurophysiological and neurological data on this.
Thank you for that, but if I may just, add on something.
Yeah.
I guess it does work in deaf-mute, definitely. Deaf-mute, a combination.
Meaning non-verbal or minimally verbal.
Yes.
Yeah, so this definitely, we have big data on children with autism. So we do have, superiority data with children with autism. We do have to adapt to their sensory needs because sometimes they are tactile defensive, sometimes they are sensory seeking. So we might have to increase or decrease the tactile input, but we do have data on other populations that motor speech interventions facilitate that group. So my guess is even for deaf, mute or minimally verbal children, this is actually going to be facilitatory. But because we know that for minimally verbal children with autism, this has been shown to be one of the effective interventions out there.
Thank you so much. It has been wonderful listening to you. Thank you.
Thank you. Pleasure.
Thank you, Dr. Arvind Namashivaya, for a highly enlightening keynote that beautifully connected neuroscience with clinical applications. May I request the moderator to kindly conclude the session?
This presentation has taken us back from the lab to the practice. You have given us an insight about how the neurosystem works and what happens when we provide the intervention, when we provide the right intervention with complete doses. Because we have been providing intervention, but we do not know how much to give and what happens, what should we expect and what we should not expect, and who is an ideal client for what kind of intervention. So you have given us an insight from the research to practice, which will be beneficial for all of us, and we can take it forward in our context and see what works with us, and we'll get in touch with you if there are any other requirements in terms of the data or in terms of how these neural prunings and whether in context of our multilingualism, whether any specific tools or the methods which you have mentioned would be more beneficial than the other one, because I guess these are all in English, whether those principles will also applicable, because this is motor learning, so I think it will be applicable in our population too, because the same principle will be applicable. But we also need more data in terms of our population, and there are areas which have not been studied till date, because the fields have just came into picture, or we can say it's just about 2 decades ago, this has got a lot of attention. So we will be having more of interaction on this, and we have already initiated, and we hope to have more interaction in future too. Thank you once again for your illustrative lecture. Thank you.
Thank you very much. Pleasure.
As our speaker has joined us online, we convey our sincere appreciation and gratitude virtually. Thank you so much, sir. Now, I request
Thank you.
Mrs. Rukhsar Khan, Researcher Officer, NIPID RC Navi Mumbai, to kindly felicitate the moderator. Moving further to our next session, the topic is High Risk Infant Developmental Supportive Care, Mission Disability Reduction and Inclusion. This session highlights the importance of early developmental supportive care for high-risk infants, focusing on prevention, inclusion and long-term disability reduction through structured early intervention strategies. To moderate this session, may I invite Dr. Olaf Cross de Camargo, Director of Can Child Center for Childhood Disability Research, Professor of Pediatrics, McMaster University, Ontario. Sir, kindly come on the stage. Our keynote speaker for the session is Dr. Zafar Minai, Honorary Secretary of Sanpepa. Sir, we request you to kindly take the stage.
Good morning, everybody.
I request the moderator to kindly take over the session.
Hello. Good morning. Thank you so much. It's an enormous pleasure to introduce to you my dear friend, Dr. Zafar Minai. As I mentioned in my keynote, he's one of the reasons that I'm here in India for the first time, and we debated a lot about the work that he is doing, about the importance of early identification, and collaborate together also with Sanbepa, which is an amazing organization in my opinion. So I'm really looking forward to your explanations and discussion later on. Please, the floor is yours, Zafar.
Thank you very much. Good morning, everybody. How many are comfortable with English? How many with Hindi? So if I go mixed, it will be okay? Yes. That's great. So first and foremost, thank you, Major Dr. Ram sir, for such a visionary approach. And when a mission like Mission Disability Prevention has a visionary like Dr. Ram sir supporting it, everybody in this hall who will be the future torchbearers of this mission, I think we stand a very good chance. And unlike other presentations, what I have come here to do is make you unlearn. How many are physiotherapists here? How many are speech therapists, special educators, and students? I hope by the end of 1 hour, we all will lose our identity and will only be champions of Mission Disability Prevention. And believe me, you will love to become the champion because you will understand you are doing a great job for your cause which you are working for, but also for the society as such. Is everybody ready to be on this journey? Yes. Bigger yes? Yes. That's it. So now, This presentation is totally evidence-based. It was published as a consensus guidelines for the Indian Academy of Pediatrics Neurodevelopmental Pediatrics chapter for developmental supportive care. It was published in Indian Pediatrics in last June. I'm very fortunate to have Dr. Anjan, who is also part of it, Dr. Sunny, Dr. Shefali Gulati. We all have contributed in this work. But more important is, what is the purpose of this talk? Well, it is the mission disability reduction as well as inclusion to make everyone in this room a champion for the cause of mission disability reduction. And how we are going to do it will be acting as a bridge between developmental pediatrician and service providers. And who are the service providers? कोई भी इंसान who is educated beyond 5th standard or even 3rd standard can be a champion. So it doesn't require me to be a developmental pediatrician. There is no conflict. हम सब एक purpose के लिए हैं. There is nothing like the one therapist is not needed, the other one is more important. It's a beautiful, I could say, a multicolored family like an orchestra, and we all need to ensure when the rhythm comes out, it's very melodious for the family, it's very melodious for the child, so that he or she attains the maximum potential for what he is born in this world. With this, the purpose is to optimize utilization for the resources, for the policymakers, as well as empower the families for attainment of maximum potential. So setting the scene, I have divided into a sort of a two presentations, and rather than two presentations, two halves. One is the policy planners. For them, what is the role of risk stratification? And for us, everyone in this hall, how we can do a better simplistic approaches for early detection, early intervention. Do we need to know ADOS? We need to know very high intensity assessment tools. Yes, they are important when you are into your individual practice, but that will be covering 10% of the disabilities which are there in the world. The remaining 90% require early identification, which any one of us in this hall can provide. With this aim, as I said, to be a champion, who are the high risk? It's the simplest way to explain that any child, any infant who are having a greater chance for developmental difficulties due to the exposure to risk factors which we'll be seeing in the subsequent slides, whether they are biological or environmental, which are during birth, before birth or after birth, and which may lead to subsequent developmental delays. And we know for sure there are multiple risk factors which can be responsible leading to this outcome. You must have been listening since yesterday the rationale. The maximum synaptogenesis takes place in the initial 3 years of life. What is synaptogenesis? होता क्या है? When a child is born, वो लेटा रहता है. 8 महीने पे वो बैठना शुरू कर देता है. By 12 months, the child is standing. What changed so that this child who was just lying down begin to sit or begin to stand? Some newer development, a new leg developing, a new neck growing? No, already both the neurons were there in the brain, and the connection between them two neurons, when they get connected as a synapse, by the process of synaptogenesis, these processes of milestones are attained. Abhi, the simplest example I can give. What is the importance of early identification? Agar one child who has a congenital dysplasia of hip, जिसमें के hip की जो हमारी long bone होती है, if nobody knows, it comes out of the socket of the pelvis, and it requires a 3-stage surgery if it is missed by 1 year, till 1 year of age. If a simple advice is given to carry this child astride the shoulder, यानी हमें ये बोलना है बच्चे को साइड में लेके चलें या उसका पाँव दूर लेके चलें, you can prevent this condition. Does it require a physiotherapy training? Does it require a developmental pediatric training or a special educated training? Or anyone can explain, at least if he sees a mother carrying a child with both the legs to approximate it, to just request कि आप इसके टांग दूर लेके चलिए. What happens if a child you see who is bottom shuffling? We know it can be one of the earliest signs of again a dysplasia. जो बच्चा कूले पे बैठ के चलता है. That child will never be able to stand till 3 years of life if the simple intervention, if somebody says to the mother, whenever the child is bottom shuffling, what happened was, aberrant pathway develops and get reinforced more the child is moving. That is the purpose of synaptogenesis. And if somebody just suggested that mother that the child needs to stand up and walk holding on the hands, that activity won't have allowed the aberrant pathway to develop. This is how synaptogenesis can be modified, and this is the beauty of early identification and simplistic intervention. Where if somebody would have suggested this child would have been at least standing and walking maximum 18 months of age if there were other no disabilities. And what are the evidences? I think in India, the best is Shubhasya Shigra. Thousands of years we know. This saying goes without fail, Shubhasya Shigra. So how early? There was a question yesterday, right from the adolescent girl. We need to intervene and help and ensure that the weight should be 40 kgs, the height should be 140 centimeters, the inches, and the hemoglobin should be at least around 12 to 14 grams mg. So the intervention needs to start from there, then continue during pregnancy, at the time of birth, and even after birth. So with this, there was a meta-analysis which proved that most importantly, if the intervention is planned family-centered, where anyone and every one of you who's sitting in the hall takes a pledge that we will ensure that the families are empowered, then only I think we can make the change. Otherwise, they will be either getting dependent on us or they're getting dependent on the centers where they are visiting. So our aim should be the families empowered so that any meta-analysis says, this study says, the best outcomes are there for these kids. And there's too much of discussion about autism. One of the biggest studies from Wiggins et al. From US, they say around 4 to 14% of the cases of autism will lose the diagnosis of autism if and if only you are able to diagnose, not only diagnose, but plan appropriate family-centered multidisciplinary intervention before 30 months of age. We were seeing yesterday the identification age is roughly around 4.5 years. So do we need to learn the ADOS of cars to identify? I think we are missing the opportunity. So what we can do, again in the subsequent slides, the simplistic way where any one of you in this hall can identify the risk factors. I am not saying I am not taking the role of a psychologist. They are my most respected members when it requires for certification or assessment. But planning is the right of the child, and every one of us has a responsibility, a moral responsibility to provide it to them. So the cutout is identification before 30 months and starting multidisciplinary intervention. And all these are evidence-based. This is not what I am saying. And then comes some economic impact. The annual cost of childhood disability ranges between $450, if we call it $500 for simplification. It comes to 40,000 rupees and go up to how much? 6 lakhs or 7 lakhs rupees. This is the yearly burden. And the lifetime cost is anywhere between 40 lakhs to 4 crore rupees. This is not a simple figure. If we are able to prevent even one child per month, we are doing the greatest service for this nation and this universe. This is the cost which would be incurred and indirectly paid by us. So in addition to what we are doing, try to understand, this again comes from James Seckerman. If the interventions are in the initial 3 years of life, that's the best investment we can do. And for that, I really thank Dr. Sharma sir, Dr. Ram sir, the visionaries who are trying to bring this concepts of early detection and early intervention. I've been working for last more than 25 years in this area. And most unfortunately, always the talks were focused on just rehabilitation. So now I feel empowered that the government, the best of the brains in the country, the best of the hands of the country, who would be the future leaders, need to understand the concept in the simplistic of the ways, how best they can perform and how best they can achieve. These are few epidemiological figures. Preterm infants, they occupy and birth asphyxia are two of the most commonest factors which are responsible for high risk. And what we can do, because you are all therapists, you are going to be doctors, you are going to be dealing with the patients, always remember to follow the very basic rule. Ask the basic history, the perinatal history, the prenatal history, take a detailed developmental history, what happened during pregnancy, observe the behaviors. We know of as physiotherapists, there can be tone abnormalities which are the first to be identified, and the most simplest way is the amyotensins and gills. In 2 months I can identify whether the dorsiflexion is tight and this child will be having a tiptoe walk, or the adductor is tight, there can be seizing subsequently. Never to forget about vision, hearing, thyroid, because it is criminal. They are correctable conditions. If we are missing ROP, if we are missing thyroid, I think we are doing great injustice to any child. So as a medico, as a fraternity of my family, I request each and everyone, whenever you see a child, you come to know about that the child is preterm and the child is still in the infancy phase. Please ask whether this child has been screened for hearing, whether this child has been screened for thyroid, and whether this child has been screened for ROP. Always remember, maternal anxiety, माँ की tension जो है, is one of the biggest deterrent for child development. So never forget, be humble to make a diagnosis in the initial years of life. You are not doing any service if I label a child as cerebral palsy in the first year, howsoever I may be confident about it, or a mental retardation, or intellectual disability, or autism. Better would be to identify the risk areas, the domain-specific areas which are requiring interventions, so that we are giving hope to the family rather than a diagnosis. Because the moment you make the diagnosis, वो family कहाँ पहुँचती है? Anyone? Google Baba के पास. So, which is all negativity. We as professionals are empowered or trained to make a diagnosis and we feel great. I think in the initial 2 years of life, that is my first learning to unlearn. Don't, even if you know the diagnosis, more important would be to say that there is, rather than a CP, a gross motor involvement in your child. There is some socialization issue in your child. There is some communication issue in your child. You know very well, you can mention the child is RMZ positive, a suspected ASD. You are not hiding anything. But if you plan intervention, I think you are doing justice to the cause, you are doing justice to the child. So, always use corrected age for the initial 2 years of life. That means reduce the prematurity for the child, so that if the child has not attained a milestone, might be the correct age is not being used. And now I come to the key issue of risk stratification. And here I will be telling you the reason when I said why you want to get restricted as a physiotherapist, as a speech therapist, myself as a developmental pediatrician, or a special educator for only the 10% of the child. This is the risk stratification, again an evidence-based slide, where there are simply 3 zones: the green, yellow, and the red zones. The green zones are the one. Good morning, sir. I welcome you. The green zones are the one which includes those which are born between 34 to 36 weeks. The moderates are the ones which require, which are born between 29 to 33 weeks, and the red zones are the ones which are less than that, 28 weeks. By weight, if it is 1500 to 2000 grammar, it comes in the green zone. 1000 grammar to 1500 grammar, and because of the SNCU, every newborn presently has a very good discharge summary report. Always, as I said to every one of you, if you want to become a champion of mission disability reduction, the only way is to go to the very basic. Just check what is written there, and you are empowered enough to know that which zone the child may come. If the child has not cried at the age, whether the blood glucose has fallen, whether the bilirubin is, what was the range of bilirubin, what was the infection, whether it was just sepsis or it was meningitis. The green and the yellow zones, as they continue, are the ones which require simplistic early stimulation, early intervention and rehabilitation. It is the red zone which requires support of my colleagues or all therapists who are sitting in this hall. They are the one who needs to be empowered and given these children from the very beginning, because they are the one who would require definitive therapy. So how to define them? The green and the yellow zone can be managed by everyone who is sitting in this hall. Right from an Anganwadi worker, a mother, the more important would be to understand, if we identify, if we support, because in the last video presentation, I will trying to empower you what simplistic ways we can do to at least tell for the ways which acts as our early intervention model for the community. The red zones are the one which requires definitive therapy, as I said, may require a developmental pediatrician or a clinic or a rehab specialist. And the outcomes, the green, yellow have very good outcome. The red may have a definitive delay or subsequent major involvement. But always remember, the entire gamut recommends that it should be family centered. The target should be the initial 3 years of life. It should be from leveling to enabling and attainment of maximum potential. It is not dependent on the age, it is not dependent on the purpose, and it is not dependent definitely on the finances. Do we need an MRI for every child? I think the simplest thing every one of us should have is a simple head measuring tape. If we are dealing with a child with developmental involvement, if we do a serial plotting, believe me, you don't require a MRI. MRI is required only for prognostication or if there is neuroregression. With a simple plotting, you can always follow if the child is falling from the head centiles. Initially it might be 15, and on IRP website you have these centile charts available from Government of India. Beautiful MCP card is there, which is with every mother. Make it a habit to have a head measuring tape in your hand, and you can do the best prognostic indicator whether this child will attain the maximum potential. A child even following the lower centiles, but following his centiles will eventually grow out of it. But unfortunately, a child who had a 50th centile head circumference in the beginning, but subsequently is falling down the line as the child ages. That means this child definitely will have, even if he is not showing any negative signs in the early stages, you need to be very cautious, because this child would definitely end up into some trouble subsequently, whether it's scholastic, whether behavioral or physical. So my first recommendation, we need to use the color coding for risk stratification. For the policy makers, this provides an opportunity. Because, as I was discussing yesterday, the point is, if we do a mammoth study, this country, this beautiful country of mine, has such a huge number that if we identify, say, observe around 20 lakh kids, as we see in the preceding slides, the prevalence is between 6 to 18%. So you can imagine, in one single state, the number would be anywhere between 2 to 3 lakhs, and any number of CDCs, any number of DICs, any number of NGOs, any number of mind specialists cannot cater to it. If we don't have proper resource allocation as well as identification and planning, what can be done at the primary level and what should be the one should be going to the DICs, so that there is no overwhelming of services. For the policymakers, I think the recommendation again is the same which I just now said, because the cost of one child of disability which I discussed is between 40 lakhs to 4 crore rupees in a lifespan. Investment in early intervention, we are blessed, as I said, if even we are able to change the life of one child, even in a month, even in a 6 month, this is the job, this is the service you are going to do to this nation and to yourself. And as I said, the red zone caters only to 10% of the patients. And that was the reason when I started my session, I said, I am not going to present to teach you anything, rather to make you unlearn, make you come out of the physiotherapist, special educator, myself from a developmental perspective, and just start being a champion of mission disability prevention. We can bring this change because I am trying to reach your horizon or raise your horizon from 10% to 90%. And these are the simplest of the tool. I think we can have it on billboards, we can have outside your clinics. Just remember them. If even you don't know any other scale, simply at 2 months the child should be having a social smile. At 4 months the child should be head holding. At 8 months the child should be sitting. At 12 months the child should be standing. At 14 months the child should be walking. 18 months there should not be any regression. By 18 months regression any of the domains. This is one of the most important slides because entire concept of early intervention can be based on this simple slide. एक बच्चा जिसने 4 महीने पे गर्दन नहीं संभाली है can never be sitting at 8 months of age. A child who is not sitting at 8 months of age will never be standing at 12 months of age. एक गांव का दद्दू भी 12 महीने के बच्चे को बोल देता है कि आपका बच्चा नहीं खड़ा हो रहा. What is the difference between me, all of us experts sitting here, and that daddu? Daddu is equally smart. I am not trying to demean him. The problem is we need to identify the building blocks which are needed. Like अगर एक बच्चे को खड़ा होना है तो उसको अपने को एंटी ग्रेविटी बिठा के सीधे पीठ से बैठना जरूरी है. उसको बैठे से एंटी ग्रेविटी खड़ा होना जरूरी है. उसको अपनी सेंटर ऑफ ग्रेविटी मेंटेन करना जरूरी है. उसको पकड़ के चलना जरूरी है. जब तक के ये 4 पैरामीटर्स आर मिसिंग, द चाइल्ड विल नेवर बी एबल टू स्टैंड. Here comes our role as experts that we should be looking for these blocks. If any of them is missing, how the heart the family can work, the child will not be able to stand because the need was in one of the blocks which was missing in this child. So I think the entire concept which in my video I will be going would be based on these simple facts: how to promote head holding, how to promote sitting, how to promote socialization. This is for autism. A child having no social smile at 2 months of age, a child sitting with hands flapping at 8 months of age, 12 months no specific papa mummy, 14 months the child may be having a tiptoe walk, not having a finger pointing, and at 18 months there can be regression. I come to this simplest of the tool, which not only identifies but you can plan the complete concept of intervention for inclusion or integration. Simple, fun question if you ask the mother, are you satisfied with your child's speech? Was there any regression? क्या आपका बच्चा बोलता था और अभी उसने पहले जो मम्मी पापा बोलना शुरू किया था बंद कर दिया है? The usual answer, if you are suspecting right, would be yes, my child is not speaking properly or not communicating properly. Here itself you know the block is there in the communication part. The second question is, are you satisfied with your child's behavior? क्या is he lost in his own world? क्या आप अपने बच्चे के behavior से satisfied है? Is he looks lost in his own world? मतलब वो अपने में मस्त रहता है. Here in itself you know for sure, if this answer is yes, that this child will have issues integrating with the society. Third question is, does your child follow 2 or 3 simple line commands by 2 years of age? We have seen in our previous slides evidence, we need to identify before 30 months and plan early intervention if we need to change the diagnosis of autism in those 15% of the cases where it will shift from autism at least to ADHD. So this third question, if the child is not following 2 to 3 simple line commands, वो 2 से 3 line हमारी बैठ जाओ रुक जाओ नहीं मान रहा है जो 18 मंथ को से फॉलो करना चाहिए था, हाउ विल दिस चाइल्ड गेट इंटीग्रेटेड इन अ नॉर्मल स्कूल? You always will be supporting him as a special educator. No, you can intervene here itself, plan the therapies so that the child learns the concept of learning. And the fourth is क्या हमारे जो पांचों सेंस ऑर्गन्स हैं, hearing, vision, touch, smell, either they are hypersensitive or hypersensitive. In that situation, it becomes difficult for the child to be self-integrated. First में you need the support of speech pathologist, second में you need the support of psychologist, third में you need the support of special educator, fourth में you require the support of occupational therapist. But is it for therapy? No, the first one is for integration for the family. The second one is for integration for the society. And the third one should be integration with the schooling. And the fourth one is self-integration. And this simplest four questions, anyone in this hall, irrespective whether he is a psychologist or not, can identify and help any family to plan intervention till subsequently the child needs a definitive assessment or further cure. I told the cutout points, they can subsequently be further subdivided. Sure. I was told 1 hour. I'm sorry. From 10 to 11?
15 minutes.
Okay. There can be few variations which are correctable. As I said, always if we see the child at 6 months, the child is not weight bearing, उस एक ही हाथ से hand check करता है, that means the child is not normal, वो hemiplegic है. If the child is not weight bearing, वो dysplasia हो सकता है. If we see seizuring, क्या वो CP होता है? नहीं, वो TBI, वो torsion भी हो सकता है, वो simple vitamin D देके rickets भी ठीक किया जा सकता है. If we see toe tip standing, it can be the first marker for Duchenne muscular dystrophy, or it can be one of the earliest markers of autism if the child is kept to standing, everyone with social smile, or it can be familiar. तो हमें हर को नहीं करना है, लेकिन if we find any risk factors, we need to label and start working. Are there any other subsequent factors which are there in this child, or concomitant factors in the child? But more importantly, start intervention. And as I said, a multidisciplinary team. Most important, there should be one goal for the child, a written goal for the child, family-centered, child-centered, where every therapist and the doctor have equal respect for each other and everyone thriving to attain maximum potential for the family and the child. I'm going to the screen time we have been discussing. I think the most simplest two advices we can give is no screen till 2 years of age and जो हम लोग करते थे outdoor plays. Can we do it? Yes. Sure? No. Yes. Thank you. No.
Good afternoon, colleagues. Thank you for your support to Mission Disability Prevention. I will be explaining some simple practical tips of early intervention. And to make it practical, we have made a sort of a play where one of my therapists would be acting as a father, and we are dealing with a child who was an NISU graduate for 1 month. Welcome. Hi.
सर ये बेटियाँ हैं मेरी 1 महीने की हो गई अभी, लेकिन देखती नहीं है सर. हम लोग कितना भी देखें या कुछ करें तो देखती नहीं है प्रॉपर.
18 months the child is not able to social smile.
Always remember, when we start early intervention, we always follow the very basic. Take a look at the decade history, ask for the preventable conditions. इसका आर्क का टेस्ट हो गया आरओपी के लिए, आरओपी वर्कअप हुआ इसका?
हाँ सर हो गया.
ओके. ओके. इसका कान का बेरा टेस्ट हुआ है?
जी सर तुरंत हो गया.
ओके. इसका थायराइड का टेस्ट हुआ है?
जी सर हो गया.
वंडरफुल. All the reports are there and they are normal. Now to plan early intervention, always remember it should be holistic. And what I mean by holistic is to address all the developmental domains, social, fine motor, visual, auditory, and definitely the gross motor as well in the first year. If we start, always it should be the position of a child in which he or she should be carried, like that. Thank you. Hello. The ideal position to carry is always astride the shoulder. When the child is awake, you can carry him down if it is sleeping. But if the child is awake, always remember to carry the child astride and upright. The leg should be as far as possible, which helps to prevent dysplasia of hip or a protector for that condition. Secondly, the child may require initially 4 finger support for the neck, which should subsequently we should reduce to 3, then to 2, then to 1, and then remove it. For vision, the child should be put around 6 to 8 inch in front of the eyes at the eye level, and the child should be spoken in simple one language and not to use madrasas. Another simple technique to promote vision is to make the child lie down, and at the foot end a series of small bulbs can be put, which can be used to promote the fixation of the light. Bright colored toys can be used, move from side to side to help fixation and following the child. For auditory and speech stimulation, again the best way is that the child should be at the eye level. The mother should be speaking to the child with gestures, with eye-to-eye contact, with clarity in one language, and not to use madrasas जो हम तुतला के बोलते हैं. For head function, the most important is to plug the fingers from inside out and outstretch the thumb. This activity should be provided around 50 times in a day by the family members. आपको समझ में आया जो मैंने बताया? आपने को इसको अपनी आँख से 6 से 8 इंच की दूरी पे रखना है. यदि पाँव करके लिखती है उधर सामने की दीवार पे बल्ब की सीरीज लगाना है. ट्वाइस से आँख के सामने दिखाने की कोशिश करना है. मुट्ठी को अंदर से बाहर खोलना है, अंगूठे को बाहर निकालना है और हमेशा इसको सीधा लेके चलना है. जी सर. इतना करेंगे. अभी अपन 1 महीने के बाद इसको वापस दिखाएंगे. Always remember, if the child had episode of birth asphyxia or HIE, or we are suspecting hypertonia or the head centers are at the lower side, we should always stop massaging and just do simple gentle touch therapy, not to provide rigorous massaging which can further promote hypertonia. Thank you. Is it clear till now? Can we do it? No yes from back side? Thank you.
गर्दन नहीं संभाल पाती है.
Now 4 months the child is not neck holding. Hello. So now the child is having a social smile at 4 months, but the child is not, the parents are concerned that the child is not having neck holding. We need to grade the neck holding as per the CDC norms, which is the simplest and which has been explained to you in detail in the workstation first. To promote neck holding, again, the first and foremost is to carry astride the shoulder with the neck support and subsequently remove the support of the neck. Carrying astride and the child holding the neck in itself provides the stimulation for the neck control. Second activity is to make the child lie down, not to pluck from the hands, help the child holding from the axilla, supporting the shoulder but not the finger should not be supporting the neck area, rather the shoulder area, and holding the axilla. The child should be made to come to sitting position, bend it forward, and again made to lie down back on the same position. This activity should be repeated 4 to 5 times in a single setting and 4 to 5 times in a day. Another simple way to promote neck holding is to take a towel, fold it, and make the child lie down on the chest, and using some bright color object at the level of the eyes, the child should be made to watch so that he or she tends to uphold the neck. Third way is to provide stimulation at the nape of the neck on the back side so that the child tends to raise the head, and which in itself supports the neck control. आपको समझ में आया? सिंपलेस्ट टेक्निक जो अपन को लेटा के बिठाना है, आगे तक के लेके जाना है, लेकिन गर्दन को सहारा नहीं देना है और हाथ से नहीं लटकाना है. Not to make the child hang from the hand, but support from the shoulder and make him sit down. Repeat this activity 4 to 5 times in one day and 4 to 5 times in 1 second. Okay? Yes. And 5.
हेलो सर, अभी तो ठीक है, गर्दन काफी सामान्य लगी, लेकिन 8 months ही हो गई है, अभी बैठ नहीं पा रही है ठीक से.
So the 8th month the child is not sitting. So now at 8 months the family is concerned that the child is not sitting independently. How best to promote it? Ideally, the first and foremost is to ensure that the child has a writing reflex. Secondly, the initial activity of neck control which we are providing, there is a small change in that activity now. When we bring the child to sitting position, pull him forward, but when it reaches the neutral position of sitting, make him sit for 30 seconds and then make him lie down. While we are promoting the neck control, we are not making the child sit for 30 seconds, but now this activity is required. For the child to have sitting, we need to continue the initial activities which we have planned for the neck control activities as well as vision, hearing and hand function. They should not be stopped, number one. Secondly, for the sitting, writing reflex is required, and to promote the writing reflex, the simplest way is to hold the child at the lower back and make him tilt towards the left. If you see the child outstretch the hands and try to prevent the fall. The same should be repeated on the other side. That means around 4 to 6 times in a one day on both the sides and 4 to 6 times in a single sitting. This will help the child develop the writing reflex. आपको समझ में आया?
जी सर.
तो अभी इस तरह से बिठाने से बिठाने वाली एक्टिविटी करेंगे, राइटिंग रिफ्लेक्स को डेवलप करेंगे. And when the child starts sitting, make the child sit and prod him twice so that he is able to outreach and hold the toy with his hands. बिठा के खिलौने जब शुरू कर देगा तो अपने को खिलौने रखना है, जिससे कि बच्चा हाथ बढ़ा के चीजों को पकड़ने की आदत डालेगा. थैंक यू.
थैंक यू सर. ये 12th month की हो गई है, लेकिन अभी खड़ी नहीं हो पाती है ठीक से.
12th month inability to stand. Hello. Now the child is sitting. The concern of the parents is the child is not independently standing. To promote standing or to attain the milestone of standing, 5 basic building blocks are needed. First and foremost, the child should be sitting independently. The child should be able to come to sitting position independently. Third, the child should be able to come to standing position from sitting position with the support of a stool or a table or a chair. And lastly, the child should be able to walk holding on. If these milestones are missing, each and every one individually should be promoted. So first and foremost would be to help the child come to sitting position, and the best way is to make the child lie down on the back, press the legs, hold the axilla, and try to tilt the child toward one side so that he starts supporting and pushing from one hand which is free and make him sit down. The same should be repeated from the other side, and it also again helps the child to come to sitting position which will be required, which is the grade 5 of sitting, and until and unless the uppermost milestone of the CDC grading of sitting is not attained, it will not be possible for the child to independently stand up. So this will be one of the foremost activities which needs to be done. Second is to make the child stand and support from both the hands and try to help him reach from one place to other, supporting both the hands. Subsequently, one hand can be supported. Lastly, there can be two persons sitting and a rope can be pulled between them so that the child holds the rope and tries to walk with the support of the ropes. Always remember, whenever a child attains something or reaches a point, he or she should be provided with a toy or whatever things the child likes so that he is positively reinforced. All these activities needs to be repeated 5 to 6 times in a day and at least 5 to 6 times in a single session.
Thank you very much. The important point is, if there is no improvement after 2 months of early intervention, please refer the child to the relevant therapist. Early intervention is not a substitute to any of my respected therapists. Let me be very clear. It's to empower them. You get a much more intact infant. It will be easy for you to give a more positive result so that it doesn't look like we are just working on a child and not getting the results. So I think it's not the end, it's the beginning of the journey. Is it okay?
Yes.
Thank you.
Thank you, Dr. Zafar Minai, for your valuable insights on inclusive developmental care. We now invite 2 questions from the audience. Volunteers, please help ma'am with the mic.
Madam, you don't need to answer, you will guide me.
That's not it. It's part is sharing an experience and
Yes,
part is
ma'am.
a question, and which has a relevance to policymakers. Now, what you showed is ideal in the community settings, and that's what we've been doing, using a doll to demonstrate. The reason we are using a doll to demonstrate, sir, is because Rehabilitation Council of India has made these new rules saying that those without a certification by RCI should not be doing therapy. And I had trained in a cascade model many of the community graduates and 12 pass to be community workers, particularly for rehabilitation and health combined. And now we have a problem with these kind of a policies where they say you cannot do it. So the special educators, the community staff who are graduates and all, they are not permitted to do that. So what we've been doing is, you always circumvent a problem. What we've been doing is to ask the mother to show what she's been instructed in the hospital, and then these people handhold to say, ensure that they do that. Plus what I have taught them, they try to demonstrate on a doll. Because touching the baby now is not permitted. So what
Madam,
you did is
with all due
excellent.
respect, I totally get what you are saying. I am on the same side of the page. That is the reason I made it very clear. We are not providing therapy.
Yes.
I am not a therapist. I made it in my very first beginning. Rather, I am saying even the therapist should outlive and start early intervention so that they get more intact cases. And very categorically I said, if there is no improvement within a month's time, the child needs to be given to the relevant therapist. So there is no boundaries, there is no discrimination, there is no purpose. There is only one purpose. Every child born should attain his and her maximum potential. If you are saying to the mother कि आपको screen time use नहीं करना है till 2 years of age, I am not bothered. मुझे नहीं लगता कि RCI would be that idiotic to come and hold off me. Why did you answer? Why did you say the mother कि you don't need to use the screen time? I understand their concerns and I respect that. And I always say when a policy is formed, it's after multiple discussions. So I never question that part. But as I said, early stimulation is anybody's right.
Yes.
There is nothing specific about. I am not saying how to give speech therapy. There was a beautiful session which explained about speech therapy. लेकिन एक बच्चे से आँख से आँख मिला के बात करना है, साफ बात करना है, बार-बार बात करना है, जो चीज दिखा रहे हैं वो उंगली से बताना है. I don't think इससे RCI या किसी को या किसी भी थेरेपिस्ट को कोई दिक्कत होना.
Yes.
So,
Yes, I agree. We are on the same plane.
Yeah.
And also for organizations now, it's become mandatory to, if we are using community staff to sort of get affiliated to RCI. That's all
totally,
policy.
purposefully, I totally keep myself away from any controversy.
We can afford to
because I think we need to be the advocates for early identification, and I think this is the high time. The biggest of the persons are there.
Yeah.
We are blessed to have this opportunity, and I hope every one of you would love to be a champion for Mission Disability Prevention. If I was successful, it's my honor. If I failed, it was my failure. I wish every one of you best in your careers and best in your services. Thank you very much.
That was the reason I raised this question, that if we sort of make mother the central to this intervention and everybody helping, which what you did, it is, I think, working. And we don't need, because we are certified by MCI, so doctors are not having any problem in showing all these. But what I'm saying is, there's so many here.
I'm again telling them, I don't want to confuse them, because they will get confused.
Yes.
You are talking about therapy.
I'm not talking about therapy. I'm talking about these early posturing and early guidance. Yeah. So this is just something I'm raising for policy point.
So actually, ma'am, we are aware of this fact that RCI has issued the directions. Actually, what happening across the country, there are many people who are not having any valid RCI license, or they are not at all having license and practicing as a specialist therapist or educator, and they pretend in the public that they are doing this. So the purpose of that order of RCI has been issued time and again. The purpose is that to prevent such people and to instill a sense of fear among the community that if you are doing such that kind of fake practice, that is not allowed. But it should never be interpreted or misinterpreted in the sense that you are handling a doll or a child or like a parent, or if even an early intervention center parents are coming or we are educating them. So that is kind of violation of that. So putting everything exactly in the word may be a difficult thing, but the sum and theme of that statement in the RCI Act is that unless until you are a professional, you should not practice rehabilitation. That is the sum and substance
That
of
I
that.
really agree with.
Yes.
But I think we need some caveat there,
If
that
is
they have
there,
a training
you are always
certificate
welcome,
course.
madam. You just send it, so we will try to incorporate in our revision of the regulations.
Thank you
That
so
would be it is always to facilitate or support the rehabilitation therapist
Yes,
and
I think-
provide the query in this.
Yeah, so if there are community centered guidance centers who are doing it, I think there has to be
In
some.
fact, madam, our ex-secretary sir has started a certificate course for caregiver for parents also. if you
Yes,
are-
yes.
So parents are very much part of this part.
Yeah, that's what I was not aware of this. That's what I suggested.
Department has supported more than 20 or 30 such courses across country for parents, and many of the parents have enrolled in the.
So they are considered certified.
Yes, they are caregiver course, but they are not given RC licenses.
Yeah, that
and
I,
certificate.
that I. Thank you.
Sir, I have your, no, I'm Jyoti. I'm a therapist, I'm a parent of a special needs child. With all these, I have gone through the cycle of different, looking at doctors and going through. So the doctors do tell, sit with the child on your side and talk to the child. Now as a parent, the reason why I became a therapist is because of that the child fails to take guidance from the parent, especially children on the spectrum. Now, many times as parents, we are quite vulnerable to so many things that come across, even more now because of the spread of social media. I think it's mandatory, it should become a part of the policy that therapy centers should allow parents to sit as a mandatory part of the room.
Yes.
Parents should not be sitting out watching a TV. Parents
yes.
should be an active participant in the therapy model.
Really,
I think that is something that's...
I think my slides very specifically highlighted even evidence-based. If the therapies are family-centered, only then early intervention works.
Yes, sir. So because it's not about parents not wanting to do something. It's parents' inability to use their existing guidance to guide a child. And to say that the parent has to do it looking at a mere monitor of what the therapist is doing, or end of the session just explaining doesn't help.
Yes.
This has been my experience as a parent as well as a therapist.
Madam, for last 22 years, my concept is a PIP, which is a parental involvement project.
Yeah,
So
but I think
each and
it has to
every-
start at the therapy levels, wherein it has to be a mandate by the organization, by the policy maker, that no therapy centers should keep the parents outside the therapy rooms.
100%. I totally endorse what you are saying, ma'am. Thank you very much.
Thank you so much.
Hello.
Hello, I'm Shabin. I'm a special educator and a master's in childcare. Sir, this practice with the Indians mostly and in the north is like from this like as soon as the mother and child get back home from the delivery and things like that, immediately the malishing which starts.
I give it the reason, you saw?
Yes.
If the child's birth is fixed here, or you are expecting, I didn't go into the technicalities of it, the mitis and angles. By 1 month we can identify the child is in hypertonia. The first simplest message that I gave was, stop massaging. आप touch therapy कर सकते हैं, आप oil apply कर सकते हैं, रग नहीं करना है, क्योंकि जितना हम रग करेंगे उतना उनका स्ट्रेच होगा और उतना उनका हाइपरटोनिया बढ़ेगा।
हाँ, ये समझ में आ गया। बट ये एक नॉर्मल ये हो गया है कि बस 4th-5th डे से ही मालिशिंग इतनी जोरदार होती है, और फिर दूसरी बात ये है कि वो
It's a norm, sir. It's
कस
very
के
difficult.
बांधा जाता है, पैर सब
Yes.
खींच के, हाथ सब खींच के बांधा जाता है। This is there in every house in the hospital by itself, by the nurses too.
The
और
best
यही
way,
पूछा जाता है कि you
that's a
are
very
bigger
practical.
than the doctors and the nurses.
That's the what you are
That's
saying.
right.
I think I face because my maximum work is on high risk newborns in India, central India. So what you are saying, I face the same problem. But if you are, what I do is I call the mother-in-law on the second visit. Because if you try to explain the daughter-in-law, she becomes helpless the moment she enters the in-laws house. So what I do is मैं बोलता हूँ कि next time उनकी mother-in-law को बुलाइए और 5 मिनट में mother-in-law की सिर्फ तारीफ करता हूँ. So that she becomes receptive to me. And then I say only one thing you can live with me is कि इसको घिस के नहीं मारना है अपने को, ठीक है ना? So then I think with that repo of 5 minutes where I was just saying about wonderful family you are having, how well you are supporting your sister, daughter-in-law, we have to, you see, we cannot fight against, as I was saying, when a policy is formed, we think it's against us. I may not be liking it, but those who are taking the policy or making the policy are much more higher intelligent than what I was thinking, because I might be thinking from my perspective. A policy is made for the country. Same are the traditions. They have been there in the society for ages. मैं हमेशा बोलता हूँ, दूसरी एग्जाम्पल देता हूँ कि आप रोटी में नमक डालते हैं क्या? वो बोलते हैं हाँ। मैंने बोला अभी आपने एक बार डाल दिया, अभी दूसरे ने भी आके डाल दिया, अभी तीसरे ने भी आके डाल दिया, घर के सारे मेंबर्स ने अगर उस आटे में नमक डाल दिया, will you be able to that रोटी? आपके बच्चे को ऊपर वाले ने पहले ही थोड़ा सा नमक दे के भेजा है, तो आप उसमें और नमक मत डालिए. These are few very simple ways, because as I said, I face this problem day in and day out कि डॉक्टर साहब अगर मालिश नहीं करेंगे तो बच्चा कमजोर रह जाएगा. तो मैं इसलिए बोलता हूँ 3 बार की जगह 4 बार तेल लगाइए, क्योंकि उसका न्यूट्रिटिव वैल्यू है, बच्चा और मोटा हो जाएगा. तो that somehow these tricks help. Thank you so much.
Thank you, sir. I'm sure audience has many questions, but kindly interact with the speaker in break time so that we can make this work in the time. Now I request Dr. Ola to conclude the session.
Thank you very much, Safar. This was a very enlightening presentation, and I think you made very well the point of the importance of sharing knowledge. Knowledge is not owned by any profession, by any person, by any organization. Knowledge is to be there to be shared as widely as possible. And I think you have a country that is blessed with a number of people that speak multiple languages, which is uncommon in many other countries in the world. And you are able to train people in these basic principles of child early identification, early child development and intervention. I was wondering if these teachings could actually be taken even further into the curriculum in schools. So you grow up learning these are basic principles like healthy nutrition, like the importance of vaccines. It is important to promote development of children. So if the children already grow up knowing that, they will see their siblings, they can help at home. Once they become parents, they are prepared, and it is not a mystery anymore how to raise a child.
Thank you.
Thank you, sir. Thank you for your moderation. Now I request you to felicitate the speaker. I also invite Dr. Head of Department of Pediatrics and Medical Education, Virat Medical College, Nepal, to felicitate the moderator.
Thank you.
Ladies and gentlemen, we will now break for tea. Before that, we invite you to visit the mobile bus therapy outside during the break, and reminding all RCI professionals to sign the CRE attendance sheet. Also, recent advances in the measurement of early childhood development at the population level. This session focuses on population level assessment of early childhood development, which plays a crucial role in public health planning, policy formulation, and monitoring developmental outcomes globally. May I invite Dr. Anil Raj Ojha, Assistant Professor of Padan Academy, Health Sciences, Nepal, to moderate this session. Our speaker for this session is Dr. Rajesh Khanna, Medical Officer, Newborn, Child and Adolescent Health, WHO. I request the moderator to take over the session.
Good morning, everyone. I'd like to welcome you all after this tea break, and we have a very fantastic and excellent talk by Dr. Rajesh Khanna. Is going to be an excellent talk. You know the importance of early childhood development, early years. I think I don't have to tell. Like it's very important. It's a time where you make or break, and I think it's very important to measure in terms of the developmental capacity of the child in early years. If we can measure it and if we can intervene and we can monitor with using these tools in later years. So I think it's very important to measure how much the child attained in terms of the milestones. So in this regard, I'd like to request Dr. Rajesh for the presentation, and the floor is yours.
Thank you. Okay. Can you hear me now? Yeah. Okay. Thank you. Thank you, Ministry of Social Justice and Empowerment and NIPED for having such an important discussion. Now, since yesterday we have been having discussions, you all have been, because I could understand that there are huge changes, and I had to make changes in my presentation, understanding that the audience is a mixed group. Since yesterday we have been talking of clinical practice, researches, individual patient-based care. I am trying to move you to a different paradigm, and that's looking into it from a public health perspective. Now the topic that I chose was, why is it important? We have been talking of what's the theme of this year's conference, early intervention. And what do we need for early intervention? People are saying that you need to start as early as possible. That's maybe within the first 6 months if possible, 1 year, 2 years. But how do we identify those children? And when I am talking of identifying those children, I am not saying those who reach at the health facility, those who are reaching the doctors, who are reaching all the therapists like you. I am talking of, can we reach out to them? Country level, population based. So I am going to focus more on that subject. A little bit on my outline, I think since there are a lot of students, it will be important to understand what we mean by the Sustainable Development Goals. Okay, you all know I will not go into the depth of it, but at least working in the community of maternal newborn child health, you should know what are these SDGs, where all the countries have made a commitment and we have to reach them by 2030. And here comes important point, we have one SDG target related to early childhood development. Okay. Then the global scales for early development, which is a landmark breakthrough in how do we identify children, how do we monitor them, and can we use the scales. Recently, over the last 4-5 years, a lot of research has been done on it, and these scales are now available in the public domain. And since we were talking of advances, I thought let me also discuss some new advances in early childhood development which are very important, we have been hearing about since yesterday. what interventions do we do at the community level? We have health facilities, we are always talking of private sector, except yesterday the UNICEF session was talking of India's public health system. But what can be done in the public health system when you go to the facilities? And what is the strategy where you can make sure that children with developmental delays, disabilities are integrated into the system? You can't bring them vertically down. You have to have a system where they can be integrated. I'm representing the Southeast Asia region made up of 10 countries, 22% of the global population, 22% of births take place here. Important thing, 33% of the population in our region, which is of course 10 countries, is children and adolescents. These are the SDG targets. There are 9 targets. I would love to have interaction with you and ask you questions, but I'm not there as an examiner. Okay. So my idea is that there are 9 targets, 9 under the health related goal, there are 9 targets. And 2 of them are related to mothers and newborns, that is for reduction of mortality. But there is an indicator related to education, that's 4, and there you have early childhood development covered, 4.2. Just a glance, as a whole the region has made, over the last 1 decade, there are 6 WHO regions, among that the region has made the most advanced progress in reducing mortality. Don't go into the details. Now this is an interesting chart, the right side one. So we measure mortality regularly. And why I am showing this is that we don't measure ECD regularly at the population level, but this is where they are reporting. Whereas ECD 4.2 we are not reporting. But just to tell you, in terms of mortality, this is a graph. We projected the rate of reduction of mortality of all the countries from 2016 to 2023 and projected till 2030. What will happen? So you still find the orange bars are the countries that are missing the target. Interestingly, over the last 2 years, 2 countries are still falling behind. They continue to fall. Something that we heard, coming to the topic. Now my background was just to give you an emphasis that yes, at the global level, we do monitor a lot of things between the countries. At the global, with the regions. And that's why this topic becomes very important. We all know that before birth, when a child is born, about 50% of brain size is already achieved, and by 18 months, 75% size is. Early childhood development, sometimes people do confuse about different terminologies. But let us try to understand. Development is a continuous process of acquiring skills and abilities based on the different domains that we have been hearing about since yesterday. But there is also a terminology that has been brought out. How do we achieve this? At the population level, and that's why you had the nurturing care framework that was brought. I'm sure Dr. Sameer will be speaking about it. I read in the agenda about it. But this is an input. And all the 5 domains of a nurturing care, they are indivisible. You have to do them together. Health nutrition is something that we are very comfortable with because that's been happening for ages. Safety and security, increasing priority, but 2 areas which we are often ignoring are responsive caregiving and opportunities for early learning. It's not in India, but overall we see huge challenges in making sure that these 2 domains get prioritized. Now, in the region we have done a lot of good work trying to prioritize ECD, but that's not good enough. So, 2 years back we had a policy review done which the ministries endorsed because WHO works is an intergovernmental organization. WHO will reach out to the government, let us know if you have done policies on this, and then they will send us the policies to make sure things are there. So if you look into in terms of early childhood development, probably all the countries have a good scenario, except for preconception care, which we don't have. Now, knowing the life cycle approach, this is one of the gap areas. Similarly, when you look into the different sectors that are involved, usually the common sectors are all involved except probably environmental health, which is only associated in few countries. We have policies, we know the science behind it, but what happens when it comes to implementation? Okay. Now, even when the government have policies, are they reflected clearly? So we did recently this assessment was done. We reached out to the governments and we evaluated in 10 countries using their 35 health sector documents to see how well is early childhood development integrated into maternal newborn childhood policies, because that's what we are all trying to say. And what we found, of course, it has been done sparingly. So don't go into the depth of it, but the key findings, it's rarely integrated across all the domains. There are various platforms where the countries are using opportunities to integrate early childhood development. Like in India, when you say you have Ashas going home, then you have facilities, health and wellness centers are there, then A&Ms go. So these are various opportunities. You have the MCP card, maternal child protection card in India. So all these opportunities are being used, and India is probably one of the countries which has used all opportunities in a very good way. Another good example comes from Nepal, where they have prioritized early childhood development as a policy document by the highest level. So there are some good examples, but still you find a lot of gaps. More importantly, whenever we talk of early childhood development, it's just about milestones monitoring. Okay, monitoring but no action thereafter. That's a big concern. Then when you go down further deep, you look into the measurement issues. You all remember there was 4.2 indicator. Now all the countries are supposed to report on it, but this is one of the indicator which usually lags behind the most. And this indicator is covering from 24 months to 59 months. Which is the best time to intervene in a child if you are suspecting anything? What's the most important time? When does the 75% of the brain growth takes place? First 18 months. And that's the time when we are not monitoring. There is no globally recognized indicator. So, if there is no data, there is no problem, no action. I know we have policymakers here, but if you want to bring this agenda to the policymakers, what do you require? The policymaker is not just dealing with children with developmental delays and disabilities. It's got a huge conundrum of issues. You need evidence, and evidence will come from data. And that's been one of the biggest gaps in case of early childhood development, which can act as a fantastic intervention to make sure that we identify those children as early as possible who require some help. So, regarding the tools, these are the tools that are available. One is the 24 to 49 months. This is a globally recognized SDG target. The second one was the nurturing care framework, which is the inputs. In those scenarios, the challenge is there are so many programs running, but how do we measure the impact, whether our programs have been successful in improving outcomes of children at the population level or at the program level? Please, I'm not talking of individual level. You think from that perspective. Individual level, you have things, but when you go to the population level, it's not feasible to do for every child. And that is why we are coming to the next crucial breakthrough that we have achieved. And secondly, till 24 months of age, 0 to 2 years is an age group where it was not covered. This is where the global scales for early development come into picture. 4-5 years, about 7 years back, there was a huge need that was filled. SDGs started from 2016. 18, it came to the forefront that we don't have a very good indicator. Or if the indicator is there, you have the ECD index, the UNICEF indicator, but it's covering from 24 months onward. Whereas you need to intervene as early as possible. So that's why this whole exercise, 6-7 years of research was done to come to a measure. When the progress was started, it was realized that we need an indicator, because again it's from the public health, population, countries comparison. How do we do that? In that scenario, it has to be globally and culturally relevant. Direct. You should be able to directly reach out to the mothers, the caregivers, or it should be something which can be done through direct observation. Okay, but it has to be simple, reliable, predictive. Can that tool also help us to predict the developmental outcomes after say 2 years? So that was the idea. Just like you have anthropometric measurements, weight, height, can we do something similar to that? So that was the thought. Because such an indicator would help us to prioritize which populations to focus on. And once you give an intervention, what is its impact? Can you compare it between different countries? And taking care of the different context. European, African, Asian, so looking into all these contexts. Easy and flexible and openly available. Okay? So the global scale of early childhood development came up with 2 tools. The third tool is going to be out, the form. One is the short form. Short form is, which is usually questions asked to a caregiver. Then there is a long form. Long form is direct observation. So when you say direct observation, so it means that it requires some bit of training, but not a big training. And then, interestingly, the idea was, how do we interpret this course? So it took nearly 2 years to come through statistical methods to come to a D score, which is the developmental score. It's a numerical value. So all your domains, motor, social, emotional, cognitive domains that we are talking of, these tools assesses this, and the score is summarized as a single numerical value. And I will tell you how it becomes useful. This is how the D score works. Now those who are, especially for the research, they will be interested to know. Now this score is just like an interval, just like you take weight. The weight of the child, 2 kgs, irrespective of any age. We have age standardized growth charts. Similarly, you can have developmental score standardized curves. Now if a child has a weight of say 4 kg, at 6 months versus at 1 year, so it raises concern. 1 year, if it's a 4 kg child, you will definitely feel, oh no, it's an emergency. Similarly, the developmental score is also like this. It is age independent. It's based on the ability and skills of the child. So once a score is defined, if a child is at 6 months, has a score of say 8, I'm just taking a hypothetical example. So probably after 6 months his score should increase from 8 to 10. Whereas if a child has a score of 8, D score of 8 at the age of 2 years, that makes you concerned. Why the score becomes important? Because when you are going in the community, this is the best parameter to raise flags. You can't have big tools. Just asking 15-20 questions, which takes 15-20 minutes from a caregiver. Tick, 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 tick. And then you convert it into a score automatically in that app, and this score is then used for monitoring, comparison and everything. So similarly, you can have a standardized D score. Just like the height and the weight curves you can have a standardized developmental for age score. Okay. Now, how was this developed? There is a question that everyone will be asking. Now, because you have to make it a culturally feasible across all the countries, first of all, a group of nearly 40 experts and researchers sat together. They developed a conceptual framework. Based on their data sets were taken from 32 countries where developmental scores were available. They were all put into a model, and then with a data set of more than 100,000 data points, these points were created. The next point is, okay, we have the score, but is it valid? Is it going to tell us what we are asking at the population level? And this was followed by a 7-country study. Again, nearly 9,000 using the same parameters to see whether the score that we are trying to use in the population is telling us what we want. And what we found was that for all the domains, the validity of this tool was as good as compared to the usual tools that were available in the country. Okay. So, what does this global scale for early development measure help us to do? It's a holistic measure, first of all. It's capturing all the domains of early childhood development that we are seeing. You don't require to adapt it when you want to use it in different countries. Open access, available for all, and it's designed to be used by field workers, community health workers. Who are the people who will reach out? We have Ashas here. We have auxiliary midwives in Sri Lanka. We have frontline health workers in Maldives. So these are the people who will collect information. We don't have to just wait for mixed survey. They can be collected routinely. And then most importantly, it will help to generate data across countries and help us to prioritize this. Now, coming to the programs, if there is any ECD specific program, how will you measure whether that program, you do all the interventions, how will you measure whether it has led to an improvement in the developmental outcomes? This is where the score becomes very important. Cost effective, feasible, can be easily done at the population level. Important thing. At present, there are currently studies going on we are trying to see whether this provides data for individual, what type of impairment it is. So there is research going on. So till the time the research findings are out, please do not use this for the purpose of individual patient tracking. Okay. And that's the right side is because when you have to go for coverage at the population level, so your precision usually gets impaired. At individual level you can be very precise, but when you go for the population level, you have to make some changes. Short form at a glance, just quickly I will just take you through. 139 items, yes, no, and total time to administer 15 to 20 minutes. It has been done in the field in 7 countries. Long form, it takes 45 minutes to 1 hour because it's direct observation. So it will take some more time. But the accuracy of both of them are important. And the choice to take whether you want to take the short or the long form will depend on your country's resources, which type of health worker you are planning to use, how much resource you want to do. If you want, you can also use the combination of both of them, it will improve the accuracy. But still, these are things in progress. Another tool now that is being also developed is the household level. So this tool, you can well imagine that it can be simply caregiver reported collections, where short form is you are asking questions. This the caregiver can self-report. So making it further easy. Tomorrow the data is moving towards household level. So another tool that is coming up. And this is the apps that are used. Now these are ongoing work on the global scale of early development. Can it predict later outcomes? Multi-country studies happening in 3 countries, sorry. Can we create developmental curves just like you have the weight and the height curves? Studies, multi-country studies again happening. Identification of children with neurodevelopmental impairments, specific impairments. Can the scale be used with some modification? This is again being carried out. So a lot of research. We started late with early childhood development, but now I think with the global scale it is opening avenues. And the data that has also been created is leading us to ask more and more questions, how we can make it feasible to reach out to the children and the vulnerable population who need it the most. Okay, since we were talking of recent advances and coming from the discussions that we are having since yesterday, I thought let me share you some other recent advances that have come up. First of all, what should a health worker do? Nurturing care is big. Nurturing care is the input that everyone needs to do. But what are the interventions within nurturing care that you need to do? We only know of health and nutrition very clearly. So this is an exercise that was jointly led by UNICEF and a global group. 1. Secondly, is there any model? We are talking of children with developmental delay. And I am not showing the data, but I think the last systematic review that was done in 2020 or 21 showed that the burden of developmental delay in children varies from region to region. It can be as high as 40 to 45% in Africa, 33% in South Asia, to 10 to 15% in Europe and North America. So huge variation we are seeing. But within the context of South Asia, what is the best model? And third, how can you deliver? How can you integrate developmental delays, children care, management into the health system? So this is the package of interventions that has been developed. I am not going into the depth, but you can see at each life stage, pregnancy, postnatal, 3 months, 3 to 6 months, and for the caregivers also, because it is also taking into consideration the caregiver mental health. One aspect which has been missing. So we have the list of interventions already identified. Secondly, another point that always concerns is, and this is coming from healthcare managers or people who go for monitoring of programs. How do you know nurturing care is being delivered in a health facility level? And when you say nurturing care, it's about 5 domains. Within the health sector, what are the things that can be done at the health facility level? Again, a checklist. And all these components are covered. usually submitted in a score of 0 to 2. I'm not going into the depth of it. But just to let you know that these tools are now available. And last, this is inclusive ECD. You are all champions yourself. You are fighting for children with developmental delay, disability. So this will be, I think, if I close this slide and ask any one of you, you will be able to speak. Is it okay? Should I do it? Okay. More importantly, what we are, it's a rights-based approach. We are talking of rights of children. We are talking of equity. Children who need the most, they should get the services the most. They need to be prioritized. We are talking of multidisciplinary domains. No, it's not easy within a health system. See, I'm a pediatrician, I moved to public health some time back, but I've been working with the systems, and it's not easy for a government to do things. We are all championing, we are all passionate about one aspect, and we'll say, oh, do it this. But from the government, you have to think from the ministry. You have to generate evidence, you have to show them how things can be done. You have to create models. And that is what I think this wonderful gathering can do moving forward. So this is inclusive ECD services. Nurturing care, please remember, is an input and childhood development is an outcome. Don't compare. That's why the terminologies that we use is nurturing care for early childhood development. Now, we have all been talking of the various models and all, but which model do you think is the most appropriate, where you can think of multidisciplinary approach, focus on early detection, focus on a comprehensive package of care? Can it happen at a health facility only? Anyone? Yeah? No. Okay, great. Can it happen only at the community? Yeah? It's collective. So what is that system known as? Which prioritizes care, people-centered care, reaching to the children. We have health and wellness centers now in India, just taking care. Sri Lanka has a history of a very strong system on which basis they have generated, and that's the primary healthcare system. That's the system that will make sure inclusivity more and more. This is a model on which most of our South Asian countries are based on. India has a two-tier system. You have health and wellness centers, and then for secondary level, you have the insurance mechanism. Maldives, Nepal, Sri Lanka are focused on a PHC-based systems. We have primary care being provided at lower levels, and this is the best system to make sure inclusive ECD. Forget about the implementation challenges, but the model is there with us. Now, the next question, and this I specifically added after Zafar's presentation, because he was talking of risk stratification, and risk stratification, first congratulations IIP that you brought it up, but when you do it at the population level, how can we do it? How can we stratify children? You cannot have clinical outcomes measured at the population level. So in that scenario, recently, again WHO did a risk stratification, a whole analysis of close to about 60 studies were taken out, and 4 indicators were identified which makes the child prone to have high mortality and morbidity. And those are age less than 2, low birth weight, preterm, and non-breastfeeding, and weight for age less than 3 standard deviation. Now when you combine 1 or 2 of these, the risk increases manifold. So it means we have a model. We know within the model, if we go at the population level, these are the type of children that are more prone to either have adverse outcomes the last thing, if we know them, then how can we give them services? And this is again something 2 years. Now WHO's thought has also changed. So since you have been here, we were initially focusing just on mortality reduction. But over the last 5-7 years, we realized that the gains of mortality are not going to be sustained unless you move into the agenda of thrive and transform. So in order to ensure thrive, the thought of well-care visits came into being. And if you look into the domains, 17 visits from 0 to 19 years. And this is what most of our countries in the region are doing. Not 17, but I'm sure 10 to 12 visits are still happening. Home visits. You have Ashas going, you have midwives going in Sri Lanka, frontline health workers in Maldives, your lady health visitors in Nepal. They all go for home visits, but they cover only the 3 to 5 years. And we lose focus after 3 years. The idea is, can we do it till adolescent? Because development is a life cycle approach. If you stop at one point, then the gains that you have achieved during childhood, you will not be able to amplify them during adolescence. So simple visits once in 3 years, 2 years, and covering 4-5 things. And interestingly, this is moving beyond health. This is looking into families, parental support, caregiver support, age-appropriate interventions. Okay. So friends, in the end, sorry, I know many of you would have bored. You have been hearing clinical, you're all coming from clinical background. But it's very important to understand that for the whole population, what are the efforts that are being taken? These recent advances, especially the global scale for early childhood development, GSED, I feel can be a game changer in helping you prioritize children who need the help and get them to come to you at an early stage, so that the interventions you can do early, your outcomes become much more better, and every child has an ability to survive, thrive, and reach their full potential. Thank you.
Thank you, Dr. Rajesh, for your excellent talk. I very rightly highlighted the importance of global scale for early childhood development in identifying those babies and children who are at a high risk for developmental difficulties. I think it's very important skill. I think, as you rightly said, it will be a game changer, definitely. Thank you for that. Thank you for the excellent talk. And the floor is open for questions. I think we can take 2 or 3 questions. Thank you.
Dr. Rajesh, Saman Madi from Sri Lanka. Thank you so much for that very excellent presentation and an eye-opening topic that you discussed about. Just want to know what's the kind of training required for the healthcare workers, because I just glanced through the tool quite fast now and I realized it's from 0 to 3, and especially we have found it's difficult for the healthcare workers with less experience to identify, to elicit developmental skills in babies, especially in the 0 to 6 months or 0 to 12 months. What is the kind of experience that you have training health workers?
Okay.
Thank you.
Actually, the short form is the one that usually requires minimalistic training, just because it's a list of questions. The long form is which will require some training. Okay. So, depending on the capacity, WHO does not recommend that you should use, if the level of the health worker is very basic, then prefer to use the short form. But if you have like midwives who are trained midwives, then you can go on to use the long form. So it will depend on that. Short form usually requires minimalistic training, Long form will require some training under supervision and maybe as per the health system some supportive supervision, which we say for everything. But it's not a resource intensive training. And the training package is also available online.
Good afternoon, doctor. So we are talking about, since yesterday, families being integrated, we are talking about the community being integrated. So can we look back to think that if mothers is first to be included even before the delivery, the obstetricians and the gynecologist, the prenatal, neonatal doctors, the pediatricians come together and tell them, because when it comes from counselors, they are not so receiving because they think we are not in power to say that. When it comes from special educators, it is not so well received. But coming from professionals as doctors to mothers, like we spoke about breastfeeding, what about daycare at a very, very early age of 9 months? What about, not singing to the child, because if they don't hear, then they don't speak. So so while there is so much of advertisement of the products that's happening, I think there is less advertisement and awareness by the government or the social organization, private organizations, with regard to what the young mothers or the fathers should be doing. Any highlight on that? Thank you.
No, first of all, thank you that you brought this up. Even the earlier presentation which Dr. Zafar presented, so there was a question on it. I feel we have medicalized child, everything too much. We are moving into medicalized care, which is not giving us that evidence. Just to take an example, we were talking of, I think you all would have heard of kangaroo mother care as a technique. Now, in our part, South Asia, keeping baby close to the mother was a norm. It's only when we were conquered by Britishers and nurseries were established. Now we have to look for evidence to say whether kangaroo care is effective or not. I fail to understand. We have our traditional norms and all. Of course, the challenge has been the evidence for it has not been passed on well. Fortunately, now Ayush Ministry coming up with it, we have excellent, and it's not Government of India, all traditional medicines are coming up in a big way. The whole center has been established in Gujarat now, WHO center, and Indian government is supporting it. So in a way, what I'm trying to say is, moving away from medicalized care, also understanding that we don't have the money to take care of different level of health workers. Your families are going to be crucially important to take care of everything, not only development. We are talking of NCDs, we are talking of mental health. These all are emerging issues. And this is also showing that health is very closely interrelated with the social fabric. So if our societies are changing, we'll have to change or look into different strategies, move away from medicalized care, involve families, keep families in the center, individuals in the center, families in the center for anything that you do. Self-care is coming up in a big, big way. Self-care modules. Again, a huge battery of modules have been generated by WHO, knowing that people will not be able to reach to the population. So those who need it, you just have to tell them that please start using this. And these are excellent for information, counseling, care seeking.
Thank you so much.
Thank you. Thank you, Dr. Rajesh, for such an enlightening presentation. And I like the most is you have, a failure, or I would say we are not doing well in all of this early child intervention. Is probably we are lacking in executing our plans and programs at intervention level, which you have guided us through your presentation. And I like where you have given so much emphasis to the family, mother, carer, because I'm a developmental pediatrician. I was talking before, whatever diagnosis, whatever we made, the first question mother will ask is, did I do anything wrong? was it my mistake kind of question, and that makes us teary sometimes and it's overwhelming. So children with this kind of disorder remains with family, so family focus, family center, family. Be it research, be it intervention. In either side, I think high time to involve family. My last question, it's just a compliment. Last question was, you talked about parents reported questionnaire. So I was just curious to know, do you give a set of question to them, or is just a pre-question, whatever comes to their mind, they report? I was not clear about it.
Okay, the household form is being developed. There will be a set of defined questions.
Okay.
And it will depend on the parent. It will work in those health systems where you don't have frontline health workers. So those you can send, and then the parents are educated, they can, so we give it to them. The idea is you give it to them at the household level, or when you have the mix survey or the DHS surveys.
Alright. So you have predefined questions, and they are open-ended questions.
But that's not been validated yet. It is under validation.
Thank you
so
so
the
much.
data has been collected, the results are being analyzed.
Okay, thank you.
I think
Thank you so much. Actually,
Thank you. Dr. Samir Dalwai is one name in India in the medical field, especially amongst pediatricians, who has really given this particular domain such a thrust that we all actually do our practices. I'm a developmental pediatrician myself. We all do our practices under his able leadership. So it's an honor to be a moderator in his session. We support him to become the president of Indian Academy of Pediatrics one day, and I wish him a good luck so that he can take this work forward, and which work you are going to hear from him. Over to you, sir.
Thank you so much. Thank you so much. Respected all the guests today. Respected Sharma sir, who's come down all the way from Delhi. Respected Ram sir. Respected Vinay bhai. All the esteemed guests who have come from all over the world on behalf of Sanpepa and NIPID for this wonderful event. Especially my friend Dr. Mr. and Mrs. Olaf. We had the pleasure of inviting them over yesterday. And I'm very, very happy to have presence of all the luminaries from WHO, UNICEF, IAP and all the other organizations we work for children. And I'm especially happy to have an eclectic mix of people here and not just the same boring pediatricians who Anjan and I are quite fed up of speaking every time without having a change in the outcome generally. Because it's not only the job of one particular specialty to impact the life of a child. It is the job or the work of all the multiple stakeholders, and it's better to have a few of each, because that is how the message will spread in the community rather than having too much of only one kind of practice, if I may say so. And that is where true inclusion begins. Can we have the presentation? And also thank you for helping me with changing this. Rahul sir, thank you very much. Yeah. I'm going to begin with where our friend, my dear friend Dr. Rajesh Khanna, I always ask him, क्या ये नाम से खूबसूरती आती है, नाम देने से? So he has spoken very nicely about how it is getting into medicalized care, and it's going to add to that how it's going to get expertized care. I'm expert hai. I'm an expert. Now earlier we thought only the medical people were expert, which was also which was also a mistake. Then of course we had social experts and social reformers like Mahatma Jyotirao Phule and so many other people. But now we have experts who are called influencers, who have a few million followers on YouTube or Instagram, who may never have probably gone to college or school or even seen one child, but they are influencing the minds of all of us how to deal with these children. So, are we going to? Acha, next one. Thank you so much. So, coming to this point, what Rajesh Bhai said so well, a population of 1.4 billion has a handful of hundreds of experts. And what he mentioned about the British colonialization and how our practices changed, I would request all of you to understand, it is not only the colonialization of India that changed the practices. The practices that were inherent in this land for 5,000 years were inherent everywhere for 10,000 years. Because these were the basic practices of mankind that in fact drew the evolution ahead. So the British came here and changed our methods, but their own methods had changed maybe 100 years before. But 1,000 years before, all of us had those things, and those things have changed. So it is not only a particular community in India or a particular state or only India that is facing this problem. It's actually a global problem because we are looking only 100 years in the past. We are not looking to the 10,000 years of human evolution and how nurturing care and early childhood development was very important to understand from that point of view. And like we mentioned, being inclusive, the best tonic for neuroplasticity, as you see, is being inclusive. And this is a wonderful team of people I am so blessed to work with. And many of my male colleagues are also very jealous of me for that reason, which is okay. The happiness that I get is much more. But it's only working with everybody from occupational therapists, speech therapists, psychologists, physiotherapists, special educators, geneticists, other pediatricians, the neurologists, psychiatrists, that we really are able to actually make an impact on the outcome for each and every child that Neuroscience Child Development stands for. So I'll begin with a question to all my esteemed audience, especially the younger members. Do you think we are born with a perfect brain? No? Yes? Why no? Who's saying we don't have a perfect brain? Okay, why are we not born with a perfect brain? Yes, ma'am?
We are constantly learning and nothing can be perfect.
Absolutely, we are constantly learning and nothing can be perfect. And this learning is driven by two neurons meeting each other. Just like friends of in college, we call each other morons. We meet at the locker or the water cooler and we exchange gossip. And that's how the news spreads and the whole college knows who's dating whom. Similarly, when two neurons meet each other and shake hands, they exchange information, and that is how they are able to share, oh, I knew this in the past. And Dr. Olaf said it so brilliantly yesterday that the brain works on patterns, on pattern learning, and that's how the brain is organized, because there are millions of stimuli every second. How do we make sense of this? It is by this pattern learning, and hence when neurons exchange information, they're able to learn, and that is the science of neuroplasticity. Because like the lady rightly said, every moment we are learning. You probably learned this morning that listening to me was a complete waste of time. No problem, it was a learning. So this happens every moment because the synapses are forming and going away. But if you look at this wonderful picture which is often shown, look at the intensity of the information being exchanged in the child's brain. The synaptogenesis, the formation of synapses, is maximum up to the 2 years of age, and in fact after that it's going down. So though we are learning, our potential to learn is not as much as it was in the first 1,000 days in the mother's womb and thereafter. And hence what is very important to understand is the science of it. Because otherwise we are just influencers without science, or we have too much of science and doctors and tools etc. without the person understanding anything. So I believe the most important tool is between your 2 years, and we need to use that as often as we can because a lot of knowledge is already there. So synaptic pruning, those synapses which are not being used, those synapses go away. Newer ones are formed which are being used repeatedly again and again. Welcome Sir Dr. Sharma. Thank you for your presence. And the role of experience and environment in shaping which connections will get stronger and which will not. Just like our friendships. We begin college at GS Medical College with 200 people in the classroom. By the time we are through, we have only about 3.5 friends, and many who are not really friends. So that's our experience that shapes it. But what's important is to learn and acquire. We need to respond to stimuli. So on one side is the technology, the other side is the environment. How the brain responds to stimulation. Change, response to the change is basically coded in the synapses, and in fact this change can be used for healing. So going ahead, this is one of my favorite books, and if you haven't read it, I would request all of you to read it by Dr. Yuval Noah Harari. And we all know that the change that happened in evolution, we all say from a 4-legged creature of animal we became a 2-legged creature. But my friends, that's not the most striking fact of difference between humans and animals. And if you look at evolution, how the brain evolved and how the genes transferred it to the next generation, the animal kingdom is based on the principle of fight or flight. You throw a stone at a dog, either the dog will bark and come and attack you, or the dog will run away. Fight or flight. That's all the animal kingdom, the brain, because the midbrain, as we say for humans, that's all their brain is capable of. Just reacting immediately with a binary, only 2 options, binary, yes or no. So, attack or run away. But as the human brain evolved within the animal kingdom, hundreds and thousands and millions of years, 6 million years to be precise, the brain evolved and it passed on from one generation to another, whatever the previous generation had learned via genetics. So we got the frontal cortex, that's the biggest change. But what did the frontal cortex give us? The frontal cortex took us beyond the binary. It gave us more options than yes or no, or 1 or 2, or plus or minus. And what were these 4 major determinants of the human brain? And the major determinants are these higher functions, which is delaying gratification, rational thought, communication, and the ability to think as a large group. What it means basically is delaying gratification. I mean, all of you must be hungry for lunch, but we have to delay the pleasure of eating till we finish our work. It teaches the child that there is a right time for everything, and we need to wait and we be patient. Why is that important? Because that helps us live in a society with each other. The second part is rational thought. It's not just yes or no. It's thinking what else. And it's not just whether I attack this person or whether I run away. Why is this person saying like this? Why is he throwing a stone at me? Why is he not throwing a stone at somebody else? What if I throw a stone back? अच्छा मैंने इसका क्या बुरा किया था? तुम होती तो ऐसा होता, तुम होती तो वैसा होता. This is all rational thinking. Dogs and cats don't sit and think. तुम होती तो ऐसा होता, तुम होती तो वैसा होता. They are just binary, but the humans have so much of option to think about, and then they have the ability to communicate it also. As Javed Akhtar writes down and tells Amitabh to tell Rekha, तुम होती तो ऐसा होता, and then expecting Rekha to respond to his communication. But by and large, there's also Shashi Kapoor in that film there, the ability to think of and as a large group. The key stellar difference between humans and animals is this. If the face of the earth has been changed and often ruined, it is because of the ability of humans to convey each other one particular thought and get everybody to act in one particular thought. This led to the establishment of concept of family, मेरे वाले, वो वाले, हमारे वाले, दूसरे वाले, दूल्हे वाले, दुल्हन वाले, the concept of families, the concept of community, the concept of a city, nagar, concept of region, the concept of state, the concept of country, the concept of nationalism, different countries, the concept of caste, the concept of religion, the concept of socialism, the concept of communism, capitalism. These are all ideas that one person was able to convey to many people, convince them, and then all of them prayed in a particular manner or did business in a particular manner. If this was not there, the face of this earth would have been different. It is that powerful. And hence, this is the most important thing of early childhood development in the first 1,000 days. The ability to acquire these 4 faculties. And where are these acquired, my friends? You may be born with a genetically perfect brain. You may be born with a genetically perfect anatomy, but you cannot walk at birth, though you have 2 perfectly looking legs. Why? You need to be nurtured through good health, and Rajesh Bhai showed the diagram of ECD. Good health, nutrition, early learning opportunities, responsive caregiving, and safety and security to be able to walk comfortably at 1.5 years of age. Similarly, for the brain to acquire all those 4 things on the right of the screen, you require human engagement. And this has happened not only in the last 100 years in India or Britain or Canada. It has happened over thousands of years, and that actually shaped the brain genetics and neuroanatomy to be able to learn these 4 categories which are most important for the human mind. And that was possible because humans lived in communities for most of the 6 million years that we've evolved, learning all these from each other. And nurturing care is not just a diagram by WHO with 5 components. That is because now we are becoming expertized. The real ECD happened in 6 million years. The early childhood development and nurturing care happened in the normal families and the large neighborhoods. And hence these functions were acquired in spite of the normal genes only by social engagement and nurturing care, which kindled these genes. So if you are born with normal genes, but if these genes don't get kindled, then you may end up not having these abilities, exactly what we talk about the science of epigenetics. But this is possible only in the community, not in Dr. Samir Dalwai's clinic or any organization or NGO. So going ahead, if you see, this is what typically represented early childhood development and the nurturing care of communities. Dear friends, I would like to point out to you that the one significant common feature in all of these is people are facing each other. But as time evolved, as we became, and just before I go ahead, any one of you, anybody who wants to be a rational psychologist, you have to be in love with a man called Lev Vygotsky, who died in his 30s before he even saw 40. But he wrote this socio-cultural theory of development, that a child learns by proximal development. He first learns from the mother, then the masi, then the chachi, then mani hui masi, then neighborhood kaki, and then the school teacher, etc., etc. That is what Lev Vygotsky told us. But as we went more and more expertise, and we became an agricultural community from a caveman, and we organized our tasks, and you are a teacher, and I am a plumber, and somebody else is a blacksmith, we started wanting to teach children to pick up certain particular attributes, and gradually the attention started shifting from each other's face to a common object. We call it education, of course, but this is what happens, and eventually this has led to a place where nobody is looking at each other, but they are looking at screens and objects, and hence now we have come to a digital world, and all of us are wondering, why is it that we are not able to curb this onslaught of screens? All of us are aware, but we are not able to stop it, because it's not just a one generational issue. The brain has been wired differently, but now with the pervasive onslaught of electronic gadgets, मुझे जो सॉन्ग किशोर कुमार का चल के तुझे मैं लेके चलूं एक ऐसे गगन के तले जहां गम भी न हो आंसू भी न हो बस प्यार ही प्यार पले. नर्चरिंग केयर इन ECD. Now आज चल के तुझे मैं लेके चलूं एप्पल के स्टोर के तले, जहाँ वो iPad भी हो, iPhone भी हो, और बस screens पले. This is what we are seeing everywhere. But what it has done is taken away neighborhoods. Not only the pados but also the padosan, and there is nobody that the child can go and meet. All of us grew up in Mumbai. My parents came from Ratnagiri and Chiplun, so my real kaki, maushi, atya, pupi, mumani, khala were not here. But बाजू वाली काकी बन गई, कोई neighbor मासी बन गई, कोई another neighbor turned into an uncle. All this has now gone because parents don't have the time to focus on all these low market things. They are focused on entering the local international school, Gorega West International School, Ghatkopar Galactic School, and all these names are convincing people that it's only academics. Going to this school, my child will become the next Einstein. And all the social maneuvering that children learned in this neighborhood. In Mumbai, sir, we live in what we call flats. On one floor there are 4 families, a Malayali family, a Sindhi family, a Gujarati family, a Marathi family. So all of us grew up learning all these diverse cultures, which is culturally okay, but neurologically, it made your brain understand diversity and was ready to deal with different people in different schools. Unfortunately, and I may probably get stoned by people for saying this, schools are based on the binary. Because what does school tell you? 1 plus 1 is 2. 2 here. 3 नहीं हो सकता है. If you say 3 you are wrong. If you say 2 you are right. So school tells you either you are right or wrong. If you answer all the correct answers more than 50%, you pass. Less than 50%, you fail. If you have passed, you are a good student. If you fail, you are a bad student. You follow all the rules of my school. You are a good girl. If you don't, you are a bad girl. Good, bad. Good versus evil. Strong versus weak. Doing well versus doing badly. This is binary. And education reduces all of us back to a binary status. Hence, there is a basic problem. There is a regression going on. The human race is exposed to the dangerous leap from cradle to classroom has bypassed the scaffolding of family that Lev Vygotsky told us about. And I believe this lack of nurturing care is actually preventing the kindling of essential normal genes, resulting in developmental and behavioral abnormalities, which is why after 83 years, we haven't identified any good genetic cause of autism or ADHD. We are still firing in the dark. Because perhaps there is no abnormal gene, perhaps there is no new virus like COVID, perhaps it's a good old genes, but perhaps the environment in which the gene needed to be kindled is missing. And hence there is an interesting regression we see that today the children are more thinking on short-term thinking, narrow, self-serving, and the real victims of this tilt are lack of reasoning, empathy, delayed gratification, and the ability to think as a classroom together, understand each other's turn, wait for turns. And what we see today is children are unable to develop empathy, unable to develop resilience or secure nurturing relationships, not because of any pollutant in the atmosphere, but a social pollution where they are not getting enough time. And hence today as a development pediatrician, sir said, we see so many children who come to us for hyperactivity, 3-year-old children, 3.5-year-old children, not sitting in this place, shouting at each other. If the teacher scolds, she doesn't want to go back to school. All of this, and when we assess them, they don't score for autism or don't score the DSM score for ADHD, but we are seeing all these children everywhere. And look at the report, look at the turn in violence, and all of you must have seen this horrific series on Netflix called Adolescence. And I'm shocked that countries which have this kind of adolescence, they are giving us guidelines, and India, which has such a massive Asia, let me say, and like Dr. Olaf said, even Brazil, which has such a holistic community, is now keeping the uncles and aunts away and following, I'm so sorry to say, but American guidelines on development, on social development of children and how we should have adolescence. It's not going to work because it didn't work for you. So why would it work for us? But the irony is, we don't have time for kaki, masi, bua, mummy, but we want to go to a counselor who's going to tell us about American methods of psychology. Sad. And that's why, if you see, in spite of everything the government is doing, the rates of suicides aren't decreasing. It's only the age at which suicides are occurring that is decreasing. That's because children learn resilience going to some cantankerous uncle in the neighborhood. एक खड़ूस uncle है, इधर चुप बैठना चाहिए. ये आंटी chilled out है, इधर जाके direct kitchen में खाना भी खा सकते हैं. This learning and this resilience, waiting for that khadus uncle to go away till you can go with that aunt in the kitchen and take something, that's where a child learns resilience, not in a developmental class or an IAP program. So my definition of nurturing care is learning to adapt to different practices in small measures, slowly, without being judged, without being said right or wrong, over a long period of time. And this cannot happen in a classroom or a program or anything that we may discover or invent. It's all artificial. And hence I always say, people say, oh, we need a developmental pediatrician, we need a therapist. Of course we need. But I say, Chachi, Masi, Bua, Mami are more important than Dr. Dalwai or any other psychologist, etc. because they will teach you in a natural way, in a safe community. So human engagement actually powers learning. So we went ahead and we published some of the research because we work with children with special needs. And we published this, and this is what I would like to draw your attention to. I'm not speaking on autism, but I can't resist taking 5 minutes out to tell you how working on this principle has helped us evolve a phenomenally better impact for children with autism. You see two children here and you obviously know the girl on the right has a problem. But I'm trying to show the comparison between the Johnny on the right here, the girl on the left, I mean. He's a 10-month-old child, so you don't expect him to speak. Good. So autism has nothing to do with speech. But look at what happens. Gradually, the first child is more concerned about his mother. He wants to go back because he's afraid. But if I start doing all this pagalpan or fun, look at what happens to the child. Now do you see him looking at me? Now do you see him developing an interest in me? But what is the girl interested in? She's not interested in her parents, the safe persons in the room. She's not worried about the doctors, the white coat people, the dangerous injection देने वाले people in the room. But look at little Johnny, वो प्यार हो गया. आँखों में इशारा हो गया. Now this I call this the Shah Rukh Khan sign. If Shah Rukh Khan does like this, the heroine comes running and hugs him. When the father does like this, the child comes running because he understands this is normal social behavior in reciprocity. But the girl isn't interested in objects. She is interested only in objects, whereas a typically developing child is interested in humans. And hence, when you look at such children, you start writing down, these are all the symptoms that you pick up. The mother says, my child has poor eye contact, no response to the call, is hyperactive, no pointing, no gesture, there's speech delay. And a conglomeration of all these symptoms, my friends, is called autism. Autism is not a tumor or an abnormal gene. The word autism only tells you that you have a combination of these symptoms, nothing more. And hence echolalia and repetitive behaviors. And hence we try to understand that we need to innovate, and in India or in Asian countries or in countries which have a strong socio-cultural foundation, can we combine child development, nurturing care and family-based culture? And we came out with this paper which we've been practicing for the last 7 years in our Child Development Center, which tells us that autism is probably a clinical condition where the child inherently, it's not because of parents, child inherently fails to connect, engage or interact meaningfully with other humans, but is inherently too engaged with and drawn to objects and patterns since birth. And this is the first clinical sign you will see in every child with autism, whatever age of the child is. And then at New Horizons we described this social behavior and communication sequence because there were no real milestones that connected the brain development and social behavior and communication development, unlike gross motor development. And here we see that communication or speech is the fourth milestone. Unfortunately, parents come to you saying, my child is not speaking. And we start with, Mama bolo, say mama, say good morning, say good evening, not understanding that the first three milestones haven't developed. The first milestone after birth is when the child starts looking at people around, the mother, the father, without getting distracted and more starts focusing on people. He learns that when the doorbell rings, the mother goes and opens the door. When the doorbell doesn't ring, the mother doesn't open the door. The child learns when do humans open the door, when do they don't open the door, when do they bring plates to the table, when do they not, when do they undress, when do they not, in front of whom do you undress, in front of whom do you not, on whose lap can you sit, whose lap you cannot. Only by observing people, and that is the second milestone that drives the neuroplasticity that we showed earlier in the pictures. By the time the child is 8 months old, he understands this is not just a motor movement, it's a communication that I am going away. This is not just a finger movement, look there, it's a message. But a 2-month-old child, if you do this or this, is just going to smile. He doesn't understand because the neuroplasticity hasn't been built up by the earlier steps. where after 8-9 months you get good non-verbal communication, the brain gets organized, and only then at 1.5 years you can make sense of sound messages. And when sound becomes meaningful, it becomes a word. A good 2 years of spoken language, then you are able to understand that 3 lines drawn on the blackboard also can produce a sound called A or B or C, and only then can you do reading and writing. So the problem here is, if the child has what we call Kam Manusha Magnata, poor human engagement, then all the symptoms come up, because no social interaction, so no eye contact, no response to the call. Child keeps running to the door and opening and shutting the door whenever he likes. We call it hyperactive, no pointing gestures and no speech delay. And all the symptoms of autism are explained starting with this one point. What's even more sinister is now this child is too focused on objects. What does he learn from objects? He learns that all objects are either arranged in or run in or work in patterns. So this child becomes a pattern ustad. And hence, he is able to, without understanding, copy nursery rhymes, jingles, and keeps on doing the same repetitive things again and again and again. So the New Horizons theory of human engagement and interaction for autism postulates that if the innate engagement is normal, the child will go on to be normal, but if that is deficient, you will have what the DSM-5 describes as autism. And hence, the treatment here is harnessing the neuroplasticity, preferably in the early childhood development age, to put the child back on the normal track. So what did we learn from our program? That coaching parents is far, far, far more important than doing this repetitive red color matching, blue color matching, shape sorting, color matching, solving puzzles with children, which in fact worsens their object involvement and pattern learning. And telling parents that this is the algorithm you need to work on. Don't start with speech or reading writing. Start with human engagement, then with human behavior, then with non-verbal, and then will come the turn of verbal. So this is a model that we have developed, which can basically be even developed online, delivered online, because largely 70% you are coaching the parents. And hence, if you put the child back in this environment, gradually you will see improvements in the children. And like I said, this is what has to be worried. So this dangerous leap has happened. That is, in the situation last few years, there is decreasing opportunities for human engagement because families have grown smaller and there is too much of exposure to objects. A 4-month-old child is kept in front of an iPhone or iPad so that he eats faster. So children who had these genes, or people who had these genes for thousands of years, but they got human engagement at birth, they were able to compensate and become better. They are losing that social input that they were getting, and they have too much of object engagement, and that's why we are seeing this huge increase in the epidemic of autism that we need to understand. And going ahead, this leap from cradle to classroom is going to get worse, because it's going to become from cradle to cloud in the next 25 years. Because with AI, you can't realize whether it's a true video or a fake video. I see every day some video of Kishore Kumar or some cats dancing abnormally, and then you realize it's AI. It's difficult for us to understand the difference between a fake video and a true video. A 4-month-old child, 5-month-old child, you want to put on those VI glasses for 2 lakh rupees, and he's seeing fairies and goblins anywhere. Mother, father can be lost. I'm seeing fairies and I'm seeing on planets. What are we trying to do? We are trying to prevent even normal understanding of the human world right from 3 to 4 months of age, and the child can't understand the difference between real and artificial. So the key learning so far is human evolution has taken 6 million years to shape our genes and neuroanatomy, but nurturing care in community is essential for neuroplasticity to drive it. The right social environment is needed. Taking that away is going to lead to increasing problems of autism, ADHD, psychosis, and hence every child's brain holds a potential to write its own story, but we need a good director, preferably in a village. And hence a 3-point agenda for all childcare workers is we must mandate teaching parents the importance of engaging with their families and friends and to find joy in human engagement. We must insist parents to take their children to parks and open spaces. And finally, we must explain to parents and schools to restrict the influence of technology at home and inside classrooms, at least till pre-primary level is completed. New parents, we need to tell them limit your child's exposure to the digital world. So I would request all newborn specialists, gynecologists to start writing this down on their discharge cards. Okay, give so many grams of protein, give so many grams of oil, and all is fine. But what about the brain? What is needed is to tell the parent that you need a scaffolding to take your child to the chachi, masi, bua, mami, connect with other parents, take them into society over a period of time. It's not a developmental program that Samir Dalwai will give you. It has to be in reality. I'll just play some videos quickly.
चाहते हैं कि आपके पीछे आपका बच्चा सक्सेसफुल हो, वो उसके कर्मों से नहीं होता. Not only his ability but the ability of the world to tolerate him and support him. कोई भी महारथी अपने आप से महारथी नहीं बना. You need world to support you. आप बच्चे को इतना इस सोसाइटी में ले जाओ कि वो कल इलेक्शन चुन के आए. अब ये क्या होता है, कौन इलेक्शन चुन के आता है? एक बंदे से मिले तो उसकी तारीफ करे, दूसरे से मिले इसको उल्टा. अभी ये बहुत नेगेटिव चीज तक जाती है, ये छोड़ दो. मगर डिप्लोमेसी तो यही बात है ना, जो उस सिचुएशन को देख के हैंडल कर सकता है. अगर आपका बच्चा लोगों को हैंडल कर सकता है, ही इज अ परफेक्टली नॉर्मल चाइल्ड एंड ही हैज फुल चांस ऑफ बीइंग सक्सेसफुल. अब रह गया कि कौन से फील्ड में काम कर रहा है. इट्स ओके, डजंट मैटर. कोई डॉक्टर है, कोई इंजीनियर है, कोई स्टॉक ब्रोकर है, कोई लॉयर है, बट इन ऑल ऑफ देम द कॉमन थिंग इज एबिलिटी टू डील विद पीपल एंड टू शो रेजिलियंस. आई लव इट. I love it. I've never heard this answer. It is so good.
And this comes from the community. Yesterday, this is a video. Miss Rivoli Sinha was here on this video yesterday, and you heard her speak about how her own child with this program has probably done better. I don't know how to take this ahead. Anyway, you heard her speak yesterday about how her child with cerebral palsy, while she was here, was conducting a 3-hour program as master of ceremonies in his school, because the maximum coaching for even parents of special children is to how to get the child to integrate in society. What are we doing? 3 hours of sessions in the morning, then go home and keep doing red color, blue color, writing ABCD 1 2 3 4 Newton's first law for the next 6 hours. All of it is pattern learning, and all patterns are binary. Yes, no, right, wrong, correct, incorrect. It is regressing the child's brain and further takes away the chance of going into the community or meeting anybody else, because the child is busy doing that program. Going ahead, what is the role of the community?
उनके पेरेंट्स को हम सिखाते हैं सबसे.
So this is about parents of special children.
हम सिखाते हैं सबसे जरूरी चीज है that your child should be able to spend 2 days with चाची, मासी, बुआ, मामी without you in their house, doing what चाची wants in चाची's house and doing what मासी wants in मासी's house. For me, a child who is able to do this is a normal child. मासी बोलते हैं ठीक है, अच्छा है, लेकिन फिर और भेज दे 2 दिन के लिए. She is welcoming him back because he is adjusting to her. He knows मासी को कैसे हैंडल करना है. मासी's house is welcome. This means that this child is normal. Why I'm saying? Because now we can survive without the mother and father. If something happens to the mother and father, eventually will happen. This child can stay with the rest of society, and the rest of society is happy to keep him with them. Then आपको वो इंश्योरेंस हो गया कि मैं नहीं भी हूँ तो मेरा बच्चे को सोसाइटी संभाल लेगी.
This is what the mother said yesterday. Her child is in school performing. Even if he makes a mistake, the teachers, everybody else are there to support him. Why? Because he has learned to be charming. He's sweet to everybody. The child who learns this, if the book falls on the teacher's hand, everybody starts laughing and making fun of the teacher. All these little 3-year-olds. This fellow has been trained to help others. He goes and picks up the book and gives it to the teacher. Guess what happens? He becomes a teacher's favorite. Teacher turns around to write on the board, this chap is having a fight. 5 children are fighting. Teacher will turn back and say, all 4 of you are the mischievous naughty ones. Not this one. He's a sweetheart. This is insurance. This is how the community will protect your child, even if it's not 100%. But for that, you need to work on that. So this is you can take a picture of this, because this is a podcast which went viral with Mr. Raj Shamani. Many of you may know him. And this you can download it, you can watch it, and you can share it with your friends, or you can write to me, I'll share it with you. It's available on YouTube. These are some of the videos that we make for parents and share for free.
रूम में जो भी काम कर रहा है एक पैटर्न में कर रहा था कि अगर डोर के पास जाना है उसे नॉक करना है, फिर कबर्ड खोलना है, फिर सोफा के पास जाना है, उस पर चढ़ना है, देन जंप करना है. तो वो सीरीज वाइज रिपीटेटिव वो कर रहा था, वही काम दिन में कई बार कर रहा था, और हम लोग रोज देख रहे थे. तो हम भी सोच रहे थे कि ये एक ही पैटर्न में क्यों कर रहा है.
ऑटिज्म का एक लक्षण ये भी है कि बच्चे पैटर्न कॉपी करने बहुत आसानी से लगते हैं, मगर इसका ये मतलब नहीं कि वो समझ के कर रहे हैं. कब करना है कब नहीं करना है ये नहीं समझते, और इसीलिए बहुत बार हम इस गलतफहमी पे रहते हैं कि बच्चे सीख रहे हैं मगर वो सीख नहीं रहे, सिर्फ पैटर्न कॉपी कर रहे हैं. इनफैक्ट आगे चल के अगर इस पैटर्न में कोई भी तब्दीली हो, कोई भी चेंज हो, तो बच्चा उसे बर्दाश्त नहीं कर सकता. बहुत सी थेरेपी अनफॉर्चुनेटली होती है जो बच्चों को मैच पैटर्न सिखाती है, और हमें लगता है कि बच्चा कुछ सीख रहा है. ऐसे पैटर्न कॉपी का कोई फायदा नहीं. जो मतलब से बच्चा करे, कब करना है कब नहीं करना है, इसकी समझ होना ज्यादा जरूरी है. सिर्फ पैटर्न करने में कोई मतलब है नहीं. So you can take a picture. There are many such videos which you can download. The point is
Working with the child with autism can at the most make the child copy patterns. It is more important to work with the parents, and that's a program we are doing with UNICEF, and I'm so thankful to Mr. Sanjay Singh for having given us the opportunity with a center in Maharashtra, where now we are helping the local therapists at the DIC to engage with the parents more, rather than the child comes and we do shape sorting, sit here, stand on one leg, jump over 2 feet, etc. And it's a community that needs to be told this, because these problems are otherwise going to keep increasing. These are some references for autism, what I spoke to you about in detail. You can of course download this QR code later and watch it. And these are some more videos, you can take a photograph. This is an article which I was invited by Outlook to write on what is the impact of absence of social neighborhoods on children. I'm sorry. And I think that's such a big tragedy, and something that we feel that parents and society should know about, how we look at preventing suicide. So these are the two articles. And
successful होने के chances किसमें?
The role of community in early childhood development cannot be overemphasized.
Successful होने के chances किसमें ज़्यादा?
Most important thing to make your child successful is the ability to help others. अगर आपका बच्चा लोगों को हैंडल कर सकता है, he has full chance of being successful.
Is there anything like born genius?
वो पता कब चलता है? 15-20 साल के बाद. अगर आपको सही परवरिश नहीं मिली, तो आपके जीनियस का कोई फायदा नहीं है.
अर्ली साइंस होता है बच्चों में, इसकी वजह से ये बंदा ज्यादा अच्छा करेगा.
The baby नाराज हो गया, लेकिन आपने थोड़ा बहुत समझाया, बहुत शांत हो गया. Resilience. Similarly, the child who is learning to play with other children is a very good sign. A child who is happy to deal relatives जो घर आते हैं, ये आप साइंस आपके बच्चे में देख रहे हो. Trust me, ये बहुत बड़ा बनेगा. Now reading is a very important ability, because page reading करने से जितना दिमाग stimulate होता है, उतना एक फिल्म देखने से नहीं हो सकता है. And that's why today we are seeing children who are born in this AI world, they are having so many problems. Today, the danger of screen time has become so bad, we need to declare it as a national emergency.
कितने लोगों को autism है?
1 out of 32 children have been found out to have autism. So, Sharma Saab is here and he has the power to impact the life of 1.3 million Indians. The simple plea, sir, would be to understand that on one hand, yes, we need to have better medical care, better DICs. Of course, you must continue that phenomenal work that the government has done in the last so many years, that you are having maybe 600 DICs all over the country, amazing Department of Child Disability, etc. But also, we must work at the community to make people understand the harmful effects of too much of the screen time and AI, and how we can make a public movement to prevent that. So going ahead, it's not just about the expertise, medical care, it's about what each one of you in this audience can do. And I would challenge, or I would say very confidently, that without having given you any tool or any machine or any guideline, I'm sure all of you today can go out and from today you can make an impact in every child's life around you, because you already have that knowledge. There is nothing that I have done differently. India doesn't, for the last 5,000 years, we didn't believe in maybe doing RCTs. I'm not saying we should not do, but it was knowledge that was by practice. And Ustad Bismillah Khan would play on his Chennai and children sitting around would pick up. And he would coach each one depending on the speed at which he is picking up. Rabindranath Tagore in Shanti Niketan didn't have classrooms divided by brick and mortar or benches. He would focus on each and every child, and everybody who learned under him at Shanti Niketan went on to become so great. So it's not about money or resources. And this is one of my favorite pictures. Come on, which movie and which is the song? So, as a pediatrician, Dr. Ulaf and Dr. Hemsagar sir, when we get a call for a delivery, you know what we are praying by the time we reach the delivery room? बच्चा होना चाहिए, भगवान बच्चे को रुला दो, ऊपर वाला बच्चे को रुला दो, so that by the time I reach, the child has started crying. But if you are a true pediatrician or a true child worker, once you reach that crying child who has been born crying, for the rest of your life you must take care that he doesn't have reason to cry. And that would be the true duty of each and every one of us. And that's why it's not a simple task. It requires a change in the mindset, and hence we mentioned yesterday that we are pushing for an independent Ministry of Children and Adolescents. Ladies and gentlemen, you've been extremely patient, especially the organizers. Thank you very much. I'm really blessed.
For your insightful and practical deliberation on nurturing care and its relevance in early childhood development. will now have a two-question interaction with the speaker. I request the audience to keep their questions brief and focused.
It's very good presentation. But can we say that it's the low neuroplasticity which is also partially responsible for the autism? And then if that is the case, what are the measures or parameters for quantifying neuroplasticity? And how do we induce the neuroplasticity mechanisms apart from whatever you have said? Very impressive. Thank you.
Thank you so much. Neuroplasticity may be measured in Harvard in some lab on some mice brain, etc. I'm not interested in it. I'm interested in if I'm sitting with a child and if I'm working with him, is he improving? But the key issue what sir has brought out is how do you harness neuroplasticity? If I have two milestones like Rajesh Bhai said, we are only looking at milestones. Suppose milestone A and milestone B. And I know the child has not reached milestone B, but age-wise he ought to be at milestone B. The key issue is not to start with B. The key issue is obviously to start with A. But the true value of a development pediatrician who can split the road from A to B into 10 parts. A better development pediatrician can split it into 20 parts. And the best one will split into 100 parts because you move from A to A1, then A2, then A3 up to A100, that's B. So the key issue for harnessing neuroplasticity is to be able to identify where the child is currently, what is the next major milestone for the child, and how do you break even that 2 milestone distance into multiple small milestones and then work with each of them with the child till he achieves that milestone. That would be my answer.
Will the development milestone can be used as a measure?
Sorry, sir?
Will the development milestone
Yes.
can they be used for
Yeah, absolutely. So we are working on this for the last 7-8 years and all our children are doing well on this. Yeah, so can we give somebody else also a chance? Thank you, sir. We can meet. I would love to talk to you.
Thank you so much, Dr. Samir. It was a brilliant presentation, and I feel humbled. Our Prime Minister recently gave a speech in Davos that was recognized all over the world, and one of the sentences was, "Nostalgia is not a strategy."
Sorry?
Nostalgia is not a strategy. So thinking about the importance of family, the importance of family communities and getting together, of course we mourn former models of how we grew up. I grew up with lots of aunties and uncles, you as well. But nowadays families are moving, are relocating, are separated all over this large country, and in other countries the same thing. Can we maybe use technology like WhatsApp groups, communications, in a way that can create new communities that are foster families or foster families that can provide that input for children to grow healthy?
Brilliant question. Thank you, Ola. We did an experiment, especially during COVID, where people could not go out much. And the mother who was coming to us for consultation, we told her, make a group of 6 mothers in your building or society. These are the terms we use in India. Multiple buildings are called societies. So make 6 groups, all of them are working at home on the laptop, so the child was all the time on screen. He said, one of you take time off from work once a week for 2 hours or 3 hours and call all the 6 children to your house. And if you are a Malayali lady, if I may say so, prepare the food that you make in your house, play the games your mother told you with all the 6 children. The next day she continues her work, another mother takes a couple of hours off, and so on and so forth. And they did this. A few weeks later, eventually school started, etc. These parents were called back to school. So they said there was no use of this experiment. I'm still getting complaints. The teachers called them and said, what did you do with your child? So why? What did he do wrong now? It's not wrong. He is the most helpful child in the class. He is patient. He is looking around for each other. He has this rational, his ability to delay gratification. He is able to rationalize some things. He is able to communicate, and she is able to look and think together as a group in the classroom. So I understand that we may not be possible for us to go back to the community, and I agree nostalgia is not a strategy, but learning, but adapting what we are doing now is important. So it may not be a real blood relative mami or a khoon ki rishtedar, it may not be a blood relative, but wherever you live, you have to be able to connect to people around. At the same time, let's understand that when we talk about change is welcome, but please be cautious about one thing. Only that change which is physiological to the human being is welcome. If it is a change which is non-physiological, if you eat too much of processed food, if you eat too much of sugar, if you eat too much of carbohydrates, if you don't work out, it is change today's time, but it's non-physiological and you're going to end up with metabolic syndrome and die early. There is change today, development, but we have so much of pollution in the air. Is that a good change? No, it's a non-physiological change. So we must speak out that yes, this change with globalization and IT and people moving around is good in some ways, but it's also harmful in some ways. And I want to stand up and be maybe that only voice which does stand for saying that this is not about my childhood and my generation. हमारे बचपन में हम ऐसा कर रहे थे. अरे अंकल चुप बैठो. It's about 6 million years, thousands of generations. I'm not talking about my child should be like me. I'm saying that we should be like the human race, because otherwise your genes are not coded for it and you are not going to be able to have a good outcome. That would be my attempt to help.
Thank you, sir. May I request the moderator to kindly summarize the session?
So what Dr. Samir Dalwai so fascinatingly told all of us is that it needs a village to raise a child. And Olaf will come to your question later in my talk, how to do that. And because he has used so many Bollywood anecdotes, I cannot not use one. मगर मुझको लौटा दो बचपन का सावन, वो कागज का कश्ती, वो बारिश का पानी.
Thank you, sir. Now I request Dr. Anjan Bhattacharya to kindly felicitate the speaker as a token of appreciation.
Bollywood continues, so you all know the phrase "मेरे पास माँ है." So that's a talk we like to give pediatricians. Don't worry if you don't have a development pediatrician or an OTS or a child development center. You have the child's mother with you, and you can make her understand what to do. That's enough. So मेरे पास development pediatrician नहीं है, OTS नहीं है, कोई बात नहीं. मेरे पास
I also invite Dr. Samahat, pediatric neurologist, IGMH, Maldives National University, to kindly felicitate the moderator. Moving further towards our next session. This session highlights the role of family-centered care in early intervention, emphasizing how active family involvement bridges the gap between research evidence and real-world practice, leading to sustainable developmental outcomes for children. I invite Shri S. Govindraj, Commissioner for Persons with Disability, as Chief Chairperson for this session. Sir, please join us on the stage. I also invite Commander Srirang Biju Sir, past President Parivar, to moderate this session. Our speaker for this session is Professor Saman Mali Priyanka Sumanasena, Professor in Pediatric Disabilities, University of Kelaniya, Sri Lanka, and Honorary Consultant Pediatrician. A very warm welcome, ma'am. I request the moderator to kindly take over proceedings.
Good afternoon, everybody. Since we are already running late, I think we'll tell our speaker to maybe start off. And her introduction has been already given. Dr. Saman Mali, she is a professor in pediatrics, disabilities, University of Kelenia, honorary consultant pediatrician from Sri Lanka. So, Madam, please start.
Good afternoon. First of all, let me thank the Ministry of Social Welfare and Justice and the REPEAT and the Sanvipa, especially Dr. Safa, who is not here now, for inviting me to attend this conference. I must say at the onset itself, I'm so pleased to see leaders from the region and global leaders coming together to make a difference to children with neurodevelopmental needs. And it's a pleasure to be here, and I'm really honored to speak to you all today. So I'm a pediatrician myself, and I have taken on the role to work with children with developmental and needs and disabilities. So this is the topic that I chose to talk about, and I think we are coming towards the end of the conference now, and we have heard so many of renowned speakers talking about so many perspectives of this approach, especially the previous speaker, and I will be so this is where I come from, just to let you know. This is beautiful Sri Lanka, my island, and you are welcome to come to enjoy the nature as well as hospitality, and to look at how we work and to share our experiences. So I think we touched a lot about family-centered care, but I'll be talking a little bit more about the technicalities of it and the core principles, and then sharing some experiences of how we work. I'll try my best to stick to time. I have 45 minutes, so I'll try to do it earlier if possible. So what is family-centered services? So I borrowed this from the CanChild website. It is an approach to provide services where every child is looked at in the context of their families. In the context of their families, I repeat that word. And it recognizes that every family is unique. I will talk to you all why it is unique in a little while. We value parentation. This teamwork goes on beyond till they become youth or even adults. This was an interesting framework that I borrowed from an Australian. The core values of early childhood intervention in family-centered care, where the child and the family are considered the apex, the environments, and the strengths of the children. So these are the core values, and then we make all those connections based on the principles that we'll be discussing in a moment. So this is a very important model if you can follow disciplinary colleagues in this audience. So what are these core principles? Family is considered as an expert. I know coming from the South Asian region, strike a balance here. Most of my colleagues would know that we have to strike a balance. Family should be considered as an expert, and children. That is extremely important. We have to recognize the uniqueness of families, from where they come from. They might come from like a mansion, they might come from different religious backgrounds, they have different values, their family structure may be different. So especially nowadays, when they come to us, they are in a very difficult situation. But when they move from us, we have to make. However, we will have all these plans. I just want to touch on two. Should the sessions be at home or at the service center? Now, those things are things that we need to think about in our context, in our country's context, in our clinical setting, because it might not be always possible to deliver services in their homes in certain settings. For example, in Sri Lanka, I'll talk to you why it is not possible. Collaboration with other institutions like education. So all these key components should be in the family-centered care plan. And most of all, communication is very important, and how we deliver the information, how we share the information, how empathetic we are, how timely is the information. All these need to be taken into consideration. I won't be able to cover everything, remember, and then we can practice this in everyday practices. So we also need to have outcome measures. Outcome measures should be child outcomes, should be family outcomes, healthcare system outcomes, as Dr. Rajesh Khanna was talking about, and then measure of processes of care is a very good tool that has been developed by, again, the Kanchal group, and that is not freely available, but such measures should be developed based on the setting. I think everything should be contextually adapted. That is very important. So this is a very basic model that has been described by UNICEF, to some extent at least, to start off with. However, as experts or as professionals working in this field, we know that we face multiple challenges. And this professional resistance about being the expert and the need to show that we know it all, you don't know anything. But that is the extreme. But I think we are not in the extreme, but we are somewhat there. We still have to work it out. We still have to. Then there are a lot of logistical barriers like qualified professionals, high workload, inability to access everybody, funding issues. So all these are there. And then the most important thing in our part of the world, and which is also being seen in other parts of the world because of huge numbers of migration. I worked in the UK before as well, like 20 years ago, and now the situation is really chaotic because of huge migrations, and people are thinking every day how to deal with these cultural variations, right? So I can imagine how we are in India with something that we have talked for years, accessing services, even us reaching the families is a problem when we are talking about terrains and poverty, distance, etc., etc. Conference, and you may see that this beautifully summarizes the processes and the outcomes which I have talked about, and it will be a nice model to look at when you are looking at your services if you don't have the access to MPOC. Let's talk a little bit about the Sri Lankan experience. I hope I'm okay with my timing. Yeah. So Sri Lanka has taken up some bold initiatives. We have developed national guidelines to manage children with developmental needs, and now these are in place. That doesn't mean we are implementing everything, but we have the guidelines. We have identified national referral pathways, which could be from the hospital, that is the neonatal pathway, the public health pathway, or through other sources like the preschool and other general practitioners, etc., or the self-referrals. We also have looked at, we are kind of between the Western and the Asian models. We are something in between, I would say. We have looked at a child development center, and then how we can, which is in the community, and referral to the hospital-based tertiary centers. Just to let you know that we have screening and evaluation processes in place. We have the hospital arm and the community arm. So this is the child health development record onto your right side, which is distributed to each and every child at birth, whether they are born in the government sector or in the private sector. And this has the basic milestones. And the public health midwife does a door-to-door. Every child gets this checked. So that's why I had the question to Dr. Rajesh. How reliable are these assessments, right? So we have the experience of this reliability, validity concerns. Then in the hospital, majority of hospitals with neonatal units, all these children undergo assessments for high-risk identification of all high-risk newborns. It's not the criteria that was shown by Dr. Safa in the morning. We have I think, slightly more, we have a lower threshold to screen them. During these clinics, we do basic visual assessments, whether they are looking at pictures, etc., social smile. We do the general movement assessment in majority of our centers. I will tell you how we do that. And then if there are any babies who are noted to have differences, they go through the Hammersmith Infant Neurological Evaluation. We also have developed a preschool tool which is not yet being nationalized, but we are in the process of getting teachers, preschool teachers trained. It is in the process. So just to let you all know, if there is anybody in the audience who doesn't know what is general movement assessment, it is a short video that is taken and looking at babies' movements. We have had training through certain research projects for more than 100 therapists and doctors in Sri Lanka for the basic general movement assessment, and for more than 50 doctors and therapists for the advanced course. So let me tell you a little bit about the center that I'm working at. So we started family-centered services in 2014, and I have to say in 2014, though we call it family-centered services, it was more expert-led services. We have converted ourselves into true family-centered services since 2020 because it's a pathway, it's learning, it's a learning process. We have to change. That is the most important thing. We have to be open to change. So we started with this at-risk infant follow-up program in this tiny clinic, which was more of a shed than a clinic, and that is the hospital clinic where we used to look at the babies. We see them like neonatal discharges, all at-risk babies, and that's on the floor doing activities by our therapists to show the families how to do the activities. Now this changed over time, and by 2019 we developed that, we got that beautiful center which is in a 5-acre land. My dream became true to build that due to the American Academy of Cerebral Palsy and Developmental Medicine, where I was a fellow in 2011. I saw these beautiful centers in Brazil and I brought back the idea, and then we had philanthropists, private sector, government all coming together to build this center. And you may see truly family-centered. So this is the mother playing with the child, and that is the therapist observing. So how they work at home. If they need any advice, we are happy to offer them advice. So this is the kind of process process how we do that, and we get referrals from the community as well as from the hospitals. We do discharge most of the children by 5 years, or sometimes even at 2 years, but sometimes the others we have identified. So we practice evidence-based medicine, we update our knowledge, we use locally validated tools if ever possible and if ever available. We are going with a highly qualified model, which I know is not practical everywhere in Asia, but in Sri Lanka it is possible because we have professionals. And we do network with global experts. That's how we get most of the trainings done. So the GMAs, ADOS, all these trainings were done through big projects, and that was done for the entire island. So for the GMAs, we have GMA calibration groups. So we do all these activities as a group, and the group is growing every day. And system-wise, we have a robust public health system. We have a good national program which is implemented in a phase-wise. And we have a committed government and private and public sector. This is our cerebral palsy register project. We have partnered with Australia for this. And this is, we have prevalence data in the eastern and the western provinces. We also have a large project called Namaste for Autism, which is being done by another group of colleagues. And these bring in a lot of expertise support to us to do evidence-based practices. I don't say evidence-based medicine because we are beyond medicine, we are rights-based, we are different. But we do have loads of challenges because there's a huge brain drain, especially the therapists. And also, none of my trainees who trained in community pediatrician subspecialty have come back to Sri Lanka. Only 2 returned. Out of like 10 we have lost to the UK at the moment, which is really sad. Then accessibility for families is not always possible. Transport is not great. Government funding is not always available. We are also struggling with the professional terrorism, where we have issues with other professionals in our own field of pediatrics. We have to deal with this. We deal with this on a daily basis. And also the government and the funders sometimes don't understand. They ask from me, "Doctor, why don't you see 100 patients a day if so-and-so is doing so?" I just say, I can barely see 20, that is all. The maximum, if I kill myself from 8 in the morning till 5 in the evening, I would be able to see 20, but comfortably, I would be happy to see 10. But when I was working in England, I could see only 3 per day. So that's how it goes. Then keep on doing research, that is very important. But it's a challenge because we do everything. We do policies, we work in the clinics, we do research, we do teaching, so it's not possible always to do everything. So just to wrap up, I want you to listen to this mother. She's famous on FB. Her name is Tanya Arsa Kulasurya. You would be able to find her somehow. Sorry, I haven't put her name. She does these TikToks or videos and puts on the FB. She's a mother who received family-centered care. So it's her story. Just listen to it. Can I play it?
Hi guys, අද ඔක්තෝබර් මාසේ 6 වෙනිදා World Cerebral Palsy Day එක. මේ දිනයේ අපි cerebral palsy සහිත දරුවන්ගේ සහ වැඩිහිටියන්ගේ නිර්වීර තත්ත්වය සමරනවා. මොකක්ද මේ cerebral palsy නොහොත් මස්තිෂ්ක අංශභාගය කියන්නේ? මෙය මුල් ළමාවියේදී ඇතිවන ආබාධිත තත්ත්වයක්. මේ තත්ත්වය බොහෝ විට දරුවා මවගේ කුසේදී හෝ ඉපදෙන අවස්ථාවේදී ඇතිවන ඔක්සිජන් අඩුපාඩුකම් හේතුවෙන් මොළයට සිදුවන හානිය නිසා ඇතිවන තත්ත්වය. ආන්‍යයට මේ තත්ත්වය ඇති වුණේ එයා ඉපදෙන අවස්ථාවේ මගේ water bag කැඩෙනවත් එක්කම වැදමහ වෙන්මුලේ නිසා. මේව සුව කරන්න පුළුවන් රෝගී තත්ත්වයක් නෙමෙයි. මෙම තත්ත්වය ඇතිවුණොත් මේ මුළු ජීවිත කාලයටම බලපානවා. හැබැයි හරි වෙලාවට අවශ්‍ය early interventions කළොත් ඒ අයගේ ජීවිතේ ගුණාත්මකභාවයෙන් වැඩි කරන්න පුළුවන්. ඒකයි අපි ආන්‍යව physiotherapy, occupational therapy, speech therapy, gene therapy වැනි therapy වලට එයාට වයස මාසයේ ඉඳලම අපි එක්කන්නේ. ඒ දේවල් හරියට කරපු නිසා අද ආන්‍ය ජීවිතයේ උපරිමයටම සතුටින් ගත කරනවා. ඉතින් කෙල ටික පවා ගිලෙන්නේ කොහොමද කියලා හුස්ම හිර වෙවි ඉගෙනගත්ත මගේ චූටි දුව ආන්‍යට මේ අභියෝගය ජය ගන්න අවශ්‍ය ශක්තිය හා ආශිර්වාදය හැම වෙලේම එයාගේ මේ ගමනේදී ලැබෙන්න කියලා මම ඒක සිතින් ප්‍රාර්ථනා කරනවා. My darling Anya, Mommy and Daddy are so proud of you and we want you to know that we will never let you down.
So she has hundreds of videos like this on her FB, and I'm one of the followers. So I asked her whether she will give me permission to play this today, and she actually translated and did she does it in Sinhala because she's Sinhalese, and she did the subtitles for me and sent it. In fact, she had sent me about 4 videos. I chose this because just to let you all know, this is nothing that we have asked her to do. This is on her own. She is doing it, and she's such an influencer on all families in Sri Lanka and worldwide. She shows how she takes her for marketing, everything, and she is encouraging families to get therapy, get proper advice, not the advices from quacks, etc. So she's doing her own advocacy. And we at IIT, we also have a lovely parents group, so parents come together and they do buddy systems for families. So we are running an ideal kind of a setting, but I know it's not possible. So suggestions to go forward in the region is I think number 1 should be we have to decide where we could come to. Ideal is there, the worst is there. We have to be somewhere middle. To start off, we can't do the best at the beginning. We start slow and grow. So we had to look at better accessibility, changing cultural barriers amongst families and also amongst professionals, looking at sustainable programs through national policies, legislation, support through life course approach, especially schooling and vocational training. I mean, when we are looking at early intervention, that's our ultimate goal. And regional data and practicing evidence-based practices is, I think, absolutely essential.
moment to say that every research should travel from evidence to field practice, right? All researchers are requiring the evidences, but it should realize the field practice also. Otherwise, it would be untranslated policy on papers, but not cannot be put it into practice. So in such a way, I wish all the very best and all the very success, and congratulations for all the organizers and resource persons presented here and made the event very historical. As Swami Vivekananda says, real freedom is aligning the mental, physical and spiritual, which assures strength, confidence and value. These all could happen or at least begin from family alone. Thanks for the opportunity. Jai Hind, Jai Bharat.
Thank you, Samanmani ma'am, for sharing valuable evidence-based insights on family-centered early intervention. We welcome 2 questions from the audience.
Hello?
I just wanted to ask one thing. You said you work as a center-based and not community-based or home-based, no? So how does it affect the services with respect to the beneficiaries or the families of the children with disabilities who cannot make it to the center? Good question. That's what I said. There are positives and negatives in family-centered services, but our center is unique because we have a trust that provides transportation allowances for families who want to reach us. So that is one way that we provide services to people who cannot reach us. Also, in Sri Lanka, there are services available in majority of hospitals close to in most of the districts with therapists, etc. So we can do shared care by referring to the local hospitals. Community-based intervention is not possible because we do not have therapists. In our center, we had 8 therapists to provide physiotherapy. We have a 15,000 registered number of patients with nearly 10,000 active families. And we are now moving into group therapy because we have only, out of the 8, we have only 5 physiotherapists, 3 speech therapists, but we have more speech therapists because we are a training center. But the permanent cadre is always getting hugely reduced due to the fact that people are migrating. So in Sri Lanka, we are not planning to have community-based therapy services for the next 20 years. I'm quite certain about it. It's not possible. Yeah. But we do the telehealth, getting families to send us videos, so we have other options to offer.
I'm already being scolded by my wife here that I'm asking too many questions. Sorry. But I just want to make a plug for the MPOC, so the Measure of Process-Oriented Care, which is a tool to measure family-centeredness. And we just released the newest version, MPOC 2.0, last month. And of course we try to sell it because we need to get some money for our center. But if it is used in research purposes, we can definitely talk and to have it free of charge.
Thank you so much. Yes, definitely. I think thanks to this conference, I got the chance to read more about family-centered care. It's always the case, right? And I already communicated to my trainees that we should actually take up a survey on family-centered care, and that's a very good measure because we are also dependent on private donors. So doing research like this and showing how families are satisfied or even not satisfied, it doesn't matter, it's all being reflected. If they're not satisfied, we have to change. So it's a good measure to see what we are doing or what we are preaching, whether it is correct or not. So thank you so much, Dr. Love.
Thank you, ma'am. I also thank our moderators. So please conclude this session.
While concluding, I think I just give one example to emphasize why the family-centered services are so important. It's a very unique example. We run many early intervention centers in Mumbai, and one NGO which basically takes care of the abandoned children. They approached us with a child who was not a spastic child, a CP child, who was not even holding her neck. And this 1.5 years or so child, within 3 months of family-centric services, because we told them that, look, you may be a center which is taking care of abandoned children or adopting center, but here work like a mother. The caregiver has to work like a mother for that child. And 3 months that child is today taking independent steps. She has started sitting, standing and she's taking independent steps. She is really a fighter. So this kind of girl, just because the approach was changed within the center, so many children are getting benefited. So this I am talking about the children who don't have a family and still they get a family and they can do so much. So imagine most of the children who come to us, they are with families, their mother brings them and they show tremendous, in fact we tell them that 75% of the therapy has to be carried out at home as homebound plan. And though they are from slums, very small, maybe 8 by 8 space they have it at house, but the kind of interaction they do it and then the kind of results they get it is phenomenal. So family-centered services are absolutely essential.
Thank you, sir, for your moderation. Now I request our chief chairperson and moderator of the session to felicitate the speaker. Dr. B.V. Ram Kumar, Director, NIPID Secunderabad, to join us on dais to kindly felicitate both the moderators. This brings us to the lunch break for the day. Before that, all the poster presenters be at the gallery, followed by the lunch. We request all the delegates to kindly proceed for lunch. I request you to return promptly post-lunch. We have sessions in 20 minutes.